from all across our state. My name is Hannah Stevens. I'm the head of child psychiatry at the University of Iowa, and I feel very fortunate to have a amazing coordinator here in the Department of Pediatrics in the Division of Community Pediatrics, Coffee Dixon, who has really made today's conference possible. I'm going to turn it over to her, and then we're going to quickly go to our speakers because we don't want to waste your time this morning when there's so many critical things to learn about mental health for youth in the community. And just want to say one more time, thank you for joining us and taking your time to learn about these important principles.
Well, good morning. My name is Coffee Dixon, and I'll be the MC for the conference today. First, I would like to recognize and thank Dr. Hannah Stevens and Dr. Laura Fuller with the University of Iowa Child and Adolescent Psychiatry, who were instrumental in planning this event. We are pleased to have an esteemed lineup of presenters this morning who will be sharing their expertise on a range of important mental health topics. A huge thank you to all the presenters. Before we begin, I'll cover a few brief housekeeping announcements. The session will be recorded. The link to view the recording will be included in the follow-up email after the conference. There will be time for questions following the presentations. Please submit questions using the Q&A feature in the webinar toolbar, and we'll cover as many questions as time allows. If you have general questions, please feel free to email me at coffee-dixon@uiowa.edu. Conference information will be uploaded to the chat. This will include the CE credit instructions, as well as the conference booklet, which includes the full speaker bios, the program schedule, and credit statements. Handouts will be made available on the CHSC website, and I will also send this link in the follow-up email. For CME disclosures of financial interest, the faculty planners and speakers for this activity have disclosed no relevant financial relationships. So without further delay, I am pleased to welcome our first speaker, Dr. Amanda Elliott. Dr. Elliott is a child and adolescent psychiatrist and clinical associate professor with the University of Iowa Department of Psychiatry. She will be presenting on the topic of evaluation and management of pediatric anxiety in the primary care clinic. Welcome, Dr. Elliott.
Good morning, everybody. I am super excited that you are all here today. Let me get my slides showing, hopefully correctly. Do I need to switch coffee or are we good?
Yes,
switch
let's
again?
switch.
Okay.
Yes.
Perfect. Okay. So I'm going to start things off this morning talking about evaluation and management of pediatric anxiety in the primary care clinic. Like Coffee had mentioned, I have no financial disclosures. I will discuss off-label use of medications given limited FDA approvals for medications in children. And these are my two primary sources of anxiety. My kids doing their sports tends to get my blood pressure and heart rate up and feeling quite anxious. Our goals this morning are discussing common presentations of anxiety in the pediatric population, discussing some screening tools for anxiety that can be used in the primary care office, and reviewing pharmacologic treatment options for pediatric anxiety disorders. So why is this important? As many of you know, huge shortage of child psychiatrists everywhere, and Iowa is particularly impacted by that. So we only have 62 child psychiatrists in the entire state, so not even one per county. The map, the red counties are places where there are no child psychiatrists. Further, of the 14 counties that do have a child psychiatrist, 7 counties only have 1, 2 counties have 2, and the only counties with more than 5 are Johnson, Polk, and Scott that still, based on population, don't have enough to meet the need. Unfortunately, these numbers aren't expected to get better. When we look at that map, those 3 in the northwest corner, the average age of those psychiatrists is 68. So we're anticipating retirements in the future. And in the best case scenario, we can graduate 4 or 5 child psych graduates a year, and it's highly unlikely that most will stay in Iowa. So why else is this important? Well, most of the time, these kids are going to come to you first. whether it's somatic complaints like stomach aches or headaches, whether it's fatigue, whether they can't sleep, or sometimes they might even come in with a chief complaint of anxiety. So I kind of put together 3 quick cases to kind of keep in mind as I talk about the medications and evaluation. And then at the end, we'll circle back to discuss a little bit about what I would do in these cases and some general principles. So first case, a 14-year-old comes in with her family complaining of fatigue. Been about 2 weeks that she hasn't been able to sleep real well at night. In context, about 2 weeks ago, she had a falling out with her friend group, and she's been excluded from her friends, teased at school, teased on social media. It's been all sorts of no fun for her. One of the screening tools we'll talk about is the Generalized Anxiety 7 scale, or the GAD-7, had a scale of 14, which is in the moderate range. For her, she has no prior history of any mental health concerns, no family history of mental health diagnosis, medically healthy young lady. So think about what you'd be already planning to do for her based on your current knowledge. Number 2, we have a 16-year-old who's presenting due to school attendance issues. Mom's getting all the emails and the calls from school due to complaints that he's sick. So he made the varsity basketball team for the first time this year. He's taking 2 AP classes. Seems to be putting a lot of pressure on himself to do well. He doesn't have any prior diagnoses, but parents describe him as a kid who always asked a lot of questions. He needed to know, where are we going? What's going on? Who's going to be there? How long do we have to stay? And would want to skip activities if he was given the opportunity. So kind of just not a formal diagnosis when he was little, but parents kind of described him as, yeah, he seemed like an anxious kid. His score on the GAD was 11, which is the low end of the moderate range. Also medically healthy young person, and both his mom and older sister have a diagnosis of an anxiety disorder. Third kiddo, 6-year-old little girl brought in by her parents due to frustration over frequent temper tantrums. They note developmentally she was a cautious, shy toddler, slow to walk, seeming like she was afraid of falling, always wanted to hold on to people, hold on to the couch, slow to warm up to people, kind of prefers to hide behind parents, didn't necessarily improve a lot, kind of as she went from infant to toddler to school age. In the mornings right now, she'll lay on the floor screaming when it's time to get ready for school, which is a pretty new thing for her. She's usually a pretty compliant kid. I don't know a whole lot of 6-year-olds that'll pick up their toys when they're asked, but she doesn't usually put up a fight about like basic tasks like that. They notice some stalling with bedtime. They have seen other kids, hear other kids like, yeah, they ask for an extra glass of water. They need to check for monsters under the bed. But to parents, this seems a little bit extra and above what they expected for a typical 6-year-old. Her kindergartner teacher has sent some notes home to parents that says, you know, basically she's a polite kid, but she has a short temper and she's not making friends very easily. She also doesn't have any prior mental health diagnoses. Pretty medically healthy, but had chronic ear infections as a kiddo, so had tympanostomy tubes placed around age 2. She was adopted at birth, so family history is not known. So first of all, what do we think this is? And then what are we going to do about it? Just to be clear, all 3 of these cases are made up from my imagination with bits and pieces of youth I may have worked with in the past, and also to illustrate some points when we get to the recommendations. So lots of developmental factors in play with anxiety that can be perfectly normal. Biologically, we're designed to have some degree of anxiety. If we're being chased by a wild animal, we should be nervous and we should run away. If we're standing in front of a group of people giving a presentation, maybe a little bit nervous, but not so much that I run for my life. These anxieties become problematic when it causes impairment and gets in your way of living your life. So whether it's function in your family, function in your school, function in community, function in work for adults. So some of the times where it's normal, infants have developmentally appropriate stranger danger. If your mom's handing the baby to a new person, they might kind of cry, arch, not really be excited about that. Toddlers start with those fears of imaginary creatures, what's under my bed, and some degree of separation anxiety is normal, especially if you've got a good relationship with your parents. When we get to school age, kids start to worry more about bad things happening. What do people think of me in school? Am I going to get good grades? How am I going to do on this presentation? Maybe worries about their health. At this age, they're starting to pay more attention to the things going on around them. So if their parents are talking about things, they're talking about topics in school, they see things on the news, some of those things might just start to weigh on what they worry about. So anxiety is fairly common. When you look at the overall period of childhood, prevalence rates of between 6 and 20% of at least one anxiety disorder. All of the numbers are on here, but when I was doing training, the person who taught us about anxiety said, generally speaking, if you think of between 3 and 5%, you're gonna hit most of the anxiety disorder prevalence for youth. So some are a little bit higher. Social phobias, particularly performance anxiety, can rise in teenage years. So specific phobias also can rise in teenage years. And then PTSD, up to 15% or more of kids who had a trauma might experience PTSD. So what do we do for evaluation? So some of the screening tools that are available in clinic, the GAD-7, I'll show you an example of it here in a couple slides. General questions about impairment related to anxiety. Treatment often is going to look more at the degree of impairment rather than pure number of symptoms. I know a lot of EPIC modules, if that's your medical record, have a GAD-7 tool built in that people can do on the tablet or before their visits. Another one that we like to use a lot is called the SCARED, or the Screen for Child Anxiety Related Disorders. There's a lot of versions available online. It has a parent and child report. There's 41 questions that you rate kind of how often that happens for you. It looks at panic disorder, generalized anxiety, separation anxiety, school avoidance, and social anxiety. So it kind of gives you a pretty good idea of what might be going on with only 41 questions. That generally doesn't take a long time for them to answer. One that a lot of our therapists might use or our psychologists use is the MASC, or the Multidimensional Anxiety Scale for Children. Unfortunately, that one's not free, so doesn't get used quite as often as the first two. So these are the questions that they ask in the GAD-7. Looks at the past 2 weeks. How often are you feeling nervous, on edge, or anxious? Unable to control your worries? You worry about different things? Trouble relaxing? Being so restless it's hard to sit still? Easily annoyed or irritable? Or afraid something awful might happen? One of the things I like to keep in mind is that even though this says GAD-7, you're thinking about generalized anxiety disorder, if you're having a rough stretch with life, if it's social difficulties, if it's grief, work trouble, you could rank pretty high on this scale, but that doesn't necessarily mean you have generalized anxiety disorder. You really want to put it in context of life history of mental health symptoms, what's going on in their social life, and put that big picture together. This is at the first page of the SCARED, and it's similar questions for the parent and child. They look at kind of these 41 questions. Is this not true or hardly ever true? Somewhat true, very often true. Most of the versions, once you get to page 2, it has a scoring rubric on the bottom, but the far column on the right gives you kind of a hint of what symptoms it's looking at. So panic, school-related anxiety, separation, social phobia, separation anxiety, generalized anxiety, are just kind of some of those initial kind of right column hints at what those questions are asking about. So further evaluation factors when it comes to making a diagnosis. In the DSM, almost all of the anxiety disorders require a 6-month duration of symptoms to give a formal diagnosis. Couple of notable exceptions in kids. Separation anxiety only requires 4 weeks of impairing symptoms, and panic disorder can be diagnosed 1 month after the psychologic symptoms, in addition to physiologic. So you think panic, you think racing heart, short of breath, numbness, tingling, but the psychologic symptoms are worries in the future about an anxiety attack happening, and or avoiding things to try to make it so that you don't have a future panic attack. Other important things are that the symptoms are not better explained by a primary medical condition. So often, depending on which symptoms they're complaining of, making sure we've ruled out things like asthma, heart conditions, thyroid disease, and other things such as that might be on your bigger differential list. Also important that this isn't better explained by another mental health diagnosis or not caused by substance use or substance withdrawal. So I'm not going to go too far into this because I don't want to steal the thunder from Dr. Elizalde coming up after me. But the first line treatment for most anxiety disorders with mild to moderate symptoms is going to be therapy. So like I said, I'll not talk too much about that, but it's really important. One of the key factors in treating anxiety, whether it's the psychiatrist, the pediatrician, the parent, the teacher, reinforcing avoidance is really important. When somebody's scared of doing something, they're not going to want to do it. So when they throw a temper tantrum about going to school and they don't have to go to school, their anxiety lowers, they feel good about the situation. Next time it comes around to go to school, they're going to still be anxious. They're going to try throwing the temper tantrum again. So the more times they avoid it, the higher that anxiety wall climbs. So kind of if school avoidance, primary treatment's going to school. Things like obsessive compulsive disorder, primary treatment's often exposure and response prevention, not avoiding those things that make you anxious. You'll hear me double down on this later, but benzodiazepines are absolutely not recommended for pediatric anxiety disorders. ACAP speaks against that specifically in their practice parameter. ACAP is American Academy of Child and Adolescent Psychiatry. If that's not an abbreviation, people know. If there's been therapy or if there are more severe symptoms, if therapy is difficult for some reason and symptoms are impairing, that's when we get to the point of considering medicine interventions. Generally speaking, the selective serotonin reuptake inhibitors are considered first-line medications for youth 6 to 18 with anxiety disorders. And then your SNRIs are considered a secondary option as well. So what has an FDA indication? It's interesting because there's age breakdowns, their diagnoses breakdowns, and then dosing. So fluoxetine in particular has an indication for OCD over the age of 7, sertraline, OCD over the age of 6, escitalopram doesn't have a primary anxiety indication, but is indicated over 12 for depression. Fluvoxamine has OCD indications over age 8. What I see when I see that list, and when I look at the things on the bottom, that there are a lot of randomized controlled studies for the SSRIs for other things, for social phobia, generalized anxiety disorder, PTSD. What I think of when I think of SSRIs is essentially an SSRI is an SSRI is an SSRI. So I have evidence that the class of medicines is safe as young as 6. I have evidence that it's useful for all of the anxiety disorders. So then it's really figuring out which of those medicines is going to be best for the patient in front of me. And generally speaking, there's not like a clear bell ringer answer that's like, oh my gosh, this medicine's going to be perfect for this person. Sometimes we're thinking if there's a family history that somebody did well on a medication, that might be a good starting place for them. Sometimes it's what am I looking at as far as side effects? What's their baseline level of symptoms? Those are some of the things that if you're trying to decide which SSRI might be going on in the background. And then some of the non-SSRIs, so clomipramine has an indication for OCD over 10, duloxetine, generalized anxiety over age 7. And then we have more randomized controlled studies looking at mirtazapine, atomoxetine, and buspirone. So I know there's a lot of information on here. You guys will have access to these slides, so don't feel like you need to scribble things down or remember it all. But looking at the SSRIs, where we generally start with dosing, how we typically titrate, what is FDA tested or approved, and what in reality we tend to use for dosing. I would say personally, the ones I use most often are fluoxetine because it has long-standing safety efficacy with the depression studies for youth. Escitalopram is generally pretty well tolerated. Also, those two are the easiest to get in liquid formulation if you're treating younger kids that aren't able to swallow pills. So that's a consideration factor as well. I also like to use sertraline quite a bit. With that you can get such a low dosing. You can go from 12.5 all the way to 200 or 250. So kind of you can really tweak and fine tune the dosing with that medication pretty easily. I put paroxetine on here because it exists, but I generally don't use paroxetine for either depression or anxiety. It tends to have a shorter half-life, slightly stronger signal in some studies regarding suicidal ideation, slightly stronger signals for weight gain, And in kids with a short half-life, sometimes it doesn't even last a full 24 hours without noticing some withdrawal type symptoms. So unless there's a significantly strong family history of everybody doing fantastic on paroxetine, it's usually not on my list of things I'm considering. Some of the non-SSRIs, so mirtazapine, venlafaxine, duloxetine. Desvenlafaxine does not have studies, even that I was finding a lot by way of randomized control studies, open label case reports. So I did not list that. And the newer serotonin medications, so your vilazodone, vortioxetine, also don't have any data for pediatric anxiety disorders right now. So the other mirtazapine, venlafaxine, duloxetine, sometimes those I'm looking at taking effect of the side effects. So mirtazapine can have a good amount of sedation or increased appetite. So if that's a symptom of their depression or anxiety, I might lean towards mirtazapine. If somebody's complaining a lot about low energy or headaches or pain, I might be looking more at one of the SNRIs. And then some of the medications that aren't generally first line or standalone, but can be used as kind of add-on or as PRN medications. So buspirone has been studied as an add-on medication, starting as low as 2.5 milligrams up to as high as 60 milligrams total daily dosing. Most of the time, once we get above 5, we might think about splitting the dose. Atomoxetine has a study that looks at treating comorbid ADHD and anxiety, and had pretty good data, slightly more beneficial for the ADHD symptoms than the anxiety, but it was considered a positive study. And then hydroxyzine can be used as needed for acute anxiety, 5 milligrams up to 25 milligrams. Some of the studies show that it might lose efficacy if it's used routinely for more than 4 months. So really trying to discourage folks from using it as a, well, I'm anxious every day before I go to school, and I'm anxious every night before I go to sleep, so I'm going to take it all the time. That might make it lose benefit over time. So kind of really using it as more of that as needed, as opposed to a scheduled because I might be anxious kind of situation. Reminder, like I said, the use of benzodiazepines does not have indications for pediatric anxiety disorders. So there's a little bit about dosing and suicidal ideation comes up later. It was one of those, do I talk about the cases right after the medicine? Do I talk about that? So I put the cases in first to make sure we could get to those. So our first case was a teenager with pretty acute symptoms in context of social stress and with no past family history. Our second teenager has some chronic symptoms that are acutely worse with stress and a positive family history. And then our third child has a really broad differential with these temper tantrums. Is this anxiety? Is there an ADHD component or an oppositional defiant component? Is this somebody who's on the autism spectrum and hasn't been diagnosed? With a very limited history, our differential is pretty darn broad. So acute symptoms in context of stress without a significant past family history, that kind of case is something that would probably be referred for therapy first. There's not a ton of evidence that a serotonin-based medicine is going to be helpful in that acute term situation. You would hope that once the stressor resolves, we either make new friends or resolve conflict with our previous friends, that those anxiety symptoms that we've never had before would go away. But learning coping skills, if we're somebody that does get that impacted by social stressors, wouldn't be a bad idea at all. In the acute situation, if sleep is really poor, could consider a recommendation for over-the-counter melatonin or some hydroxyzine temporarily to help them with sleep since they're complaining of that fatigue component. Our second young person, teenager with fairly chronic symptoms. So they didn't have a full-blown anxiety disorder, but definitely had an anxious temperament as a kid. Slow to warm up to things, anxious with how they were learning new skills. And then now we've got a lot of pressure. We're noticing a lot of those somatic symptoms, lots of things that make us think there's some anxiety going on, and a positive family history. One of the other things I wanted to say with these two, like I mentioned when we looked at GAD, the GAD-7, the score doesn't necessarily tell you the whole story. So when I put these two cases together, the first case actually had a higher GAD than the second case. But she's acutely distressed and is somebody who has a high reporting level of symptoms. The second person had a lower score, but has more chronic symptoms and might underreport. So that's something to keep in mind too, that it's not just a score is this, that means mild, moderate, severe. Kind of taking it in context is important too. So teenager, chronic symptoms that are acutely worse, positive family history. This one really could go either way. This is one that probably an SSRI would be a good starting spot and referring to therapy. Oftentimes when you have those high schoolers that are really busy with their classes, with sports, they'll say they don't have time for therapy. I really encourage folks that it's important and they should still consider it, while also thinking that an SSRI is probably reasonable, especially given the family history. Third kiddo, honestly, I don't know. When some of the young kids come in with really generic symptoms that we don't have clear causes for, we do want to be thinking of all those things. Could there be an anxiety component? Absolutely. Could there be an ADHD or oppositional defiant component? Absolutely. Could this be a kiddo who is on the spectrum and kind of now that we're facing more social interaction in the school setting, our symptoms are kind of blowing up and our schedule that we've had for the past 4 or 5 years is different and we don't like it. So in this circumstance, probably looking at referrals for ongoing evaluation. Potentially things like occupational therapy, speech therapy, psychiatry or psychology to really get a bigger dive into what those symptoms are, when they're occurring, and what we think might be going on. Almost anytime a kid is having persistent tantrums, family-based therapy would likely be helpful. If we're working with this kiddo, I probably would not be starting an SSRI at this first visit. If we're doing some of those workups, if we're trying to do some therapy and we're still really irritable, we're still seeming to be anxious at nighttime, we're still having those meltdowns, an SSRI, if we think anxiety is playing a role, is not inappropriate because there are some of those studies that show efficacy and safety as young as age 6. So pesky black box warning. We do have the study from 2014 that talks about the previous studies that came out with the black box warning. So they did a meta-analysis of 27 studies. Of note, this is for treating depression, not primarily anxiety. And they looked at in the placebo group, there was a 2% rate of the group not taking medication that reported suicidal thoughts today. The other group that is on medications reported 3% of them were having suicidal thoughts. So it increases the risk of thoughts, but it didn't necessarily increase attempts and it didn't increase deaths by suicide. What they did see after the black box warning came out, people prescribed less, so depression and anxiety weren't being treated. Then we actually saw an increase in deaths by suicide. So we always talk to families about there is this potential risk that it could increase thoughts of suicide, but that it's not something we necessarily expect. We encourage the kiddo that we're working with to talk to their parent, regardless of what symptoms they're having, but especially if they're having thoughts about their safety, that they should talk to their family about it. Other medication pointers, big picture. We want to start low and go slow. Depending on your patient, if you know them pretty well, if they're sensitive to medicines, I'll even take some of the medicines that come in tablets or liquids, half of the starting dose for 3 or 4 days, get their body used to it before I go to the kind of traditional starting dose. Can start to titrate after 1 week. And then if you're not seeing much improvement after 4 to 6 weeks, you can increase the dose further. The other thing to make sure parents and kiddos know about is that it does unfortunately take time for these medicines to kick in. Oftentimes 6 to 8 weeks for full benefit on the therapeutic dose. Oftentimes you'll start to see benefits within that, towards the end of that first month. But I don't want people to be discouraged or disappointed if like 2 or 3 weeks and they're like, I still don't feel any better. Giving them that timeline that it might take a little bit of time. Things we see most commonly as far as side effects, definitely the GI side effects, nausea, vomiting, diarrhea are some of the most common that we see. Headaches can also be pretty common. What I tell folks with those physical symptoms in particular It happens the most when your body is getting used to it. So for most folks, it's going to happen the most in the first 7 days of starting or of a dose increase. And then once your body gets used to it, those symptoms should go away. If they're not going away, I want you to let me know, because we might want to think about a different medicine if your body doesn't like this one a whole lot. Sleep changes. For some people, a medicine might make them sleepy. For other people, it might make them more awake. You can target that by doing dosing, time of day. So if it's a medicine that makes them sleepy, have them take it at bedtime. If there's a medicine that makes them more activated, take it in the morning. And kind of listening to your patient with what they say with that. For example, fluoxetine is generally considered an activating medication. 90+% of people take it in the morning. If somebody tells me, hey, I take my fluoxetine and it makes me sleepy, it's unusual, but I believe your lived experience, and I tell you to take it at nighttime. There's no absolute right or wrong with that. There is some evidence for activation. So like a physical restlessness or anxious feeling with some of the medications. Fluoxetine tends to have the highest risk of that, and sertraline as well. So often if somebody's already on the panicky side or physical anxiety side, I might lean towards something like escitalopram to try to avoid that side effect. Some people experience sweating, dry mouth, or sexual side effects with antidepressant and anti-anxiety medicines as well. And like I mentioned before, the slight increase in suicidal thoughts, hypomania if someone has a genetic risk or otherwise risk for bipolar disorder, and then serotonin syndrome. We discussed kind of what to look for as far as heart racing, sweating, muscle spasms, things like that. So there are some key studies if folks want to read up about it. The ACAP website has a lot of really good resources that you don't have to be an ACAP member to access. So our practice parameters for all of our diagnoses are on their website. The Child and Adolescent Anxiety Multimodal Study is another one that looks at anxiety disorders. There's a short-term and an extended-term version of that study available. The POTS is the Pediatric OCD Treatment Study. Here are a bunch of the references for the medications. And here's my email address, really good resources from ACAP. So they have a list of facts for family sheets. Again, all the diagnoses, but also some psychosocial situations. So there's like bullying, community disaster, things like that as well. And then practice parameters for all of the key diagnoses as well. As many of you might also know, our team at the hospital provides a consult service as well as referral service if there are questions that you're working with a patient or a family and are trying to figure out how you best want to answer. So that brings me to the end, almost perfectly on time for questions.
Yes. Well, thank you, Dr. Elliott. And I appreciate you covering so much in this short time. I'm sure you could spend a full morning on this topic alone. So thank you. So we'll dive right into questions. Are there any preferred medications to treat combined anxiety and ADHD?
So that's a great question. There's what's been studied and what is clinically done in practice. So there have been studies primarily looking at atomoxetine, since it tends to function most like an SNRI, looking at anxiety and ADHD that shows benefit. That said, kind of when we're looking at both and we think about that timeline for benefit for symptoms of being 6 to 8 weeks when we start an antidepressant, if there's both things going on, oftentimes treating the ADHD, if they're somebody that's appropriate for a stimulant, you're going to see that effect within a couple of days. So rather than waiting an entire quarter for a kiddo that's in school for their symptoms to get better, potentially starting with the ADHD treatment first, unless their anxiety is absolutely so severe, you think the stimulant might make their symptoms worse. So generally speaking, kind of there's the two answers. Textbook, the atomoxetine has evidence behind it. Clinically speaking, we'll often treat the anxiety first, or I'm sorry, the ADHD first, and then see what anxiety is remaining. There are a large subset of kids with ADHD and anxiety that over time, when they're not getting their work done, they're being redirected all the time at class, their parents are disappointed because they're getting emails every day. Some of that anxiety builds because of their ADHD. So there are times when we treat the ADHD, some of their anxiety symptoms go down.
Okay, thank you. And then there was a question, do you recommend using GAD-7 or scared more? Or is it more dependent on age?
Um, So I think big picture, the scared gives you more information because the GAD is primarily designed for generalized anxiety. And for example, that first teenager that's having a lot of stress, her score was really high, even though she probably doesn't have a baseline anxiety disorder. Whereas the scared looks at those multiple categories of anxiety. It also has those versions where you see what the kid experiences and what the parent observes. So it gives you a little bit of that built-in collateral with your evaluation. So if I had to use one to give myself the best differential, I would pick the scared.
Okay, thank you. Um, you talked about SSRI and suicide ideation. I don't know if you wanted to, there was a question on that. And then also starting SSRI at a younger age, if you wanted to add anything more.
Um, so I generally share what I told you guys, that there's a 1 to 2% increased risk of suicidal thinking when people are on the medication, but I generally don't see an increase in attempts or death by suicide. And that over time, when people were not prescribing the serotonin-based medicines, we saw more deaths by suicide. Um, some families are really, if they're, especially if anxiety runs in the family, they get really anxious about that. And so some want to start low dose, some like, just kidding, we want to do therapy first because this makes us so anxious. But generally kind of thinking about what our safety plan is if these happen, and kind of trying to alleviate their worry, like it certainly doesn't happen to most people. Um, then the second question about younger ages, for young kids, I'd say below 9-ish. The medicines aren't always going to be quite as helpful. A lot of the things that are often happening with anxiety have a correlation with behavior, whether it's irritability, whether it's meltdowns, whether it's refusals. So oftentimes with that younger cohort, kind of therapy and involving the parent on some angle, so that they can approach things together is going to be the most helpful. We do have safety data as low as age 6. So there are cases in which the anxiety symptoms do seem really severe. The kids that can tell you what their thoughts are, there are kids that can tell you pretty well that like, this does sound a lot like generalized anxiety or a severe social anxiety. And I think you might benefit from medicine as well as therapy. So I'm comfortable using it as low as 6 if I need to. But I would generally say most often I use it older elementary to middle school when I start. And there's generally not a lot of safety or efficacy data under the age of 6.
All right, thank you. There was a question about does hydroxyzine affect the cognition in children?
Generally speaking, I don't see that. So certainly if they're taking a dose before they go to school and they experience sedation from it, they might not be totally tuned in to what's going on in class. But we don't see any of like those anticholinergic side effects that you see in kind of the more elderly populations that impact cognition. So I would say in kids, the only times hydroxyzine would be affecting cognition and function would be if they're sedated by it.
Thank you. How can primary care providers differentiate between developmentally typical worries and more clinically significant
Yeah.
anxiety?
Probably no 100% perfect answer to that, unfortunately. One, I would say with the anxiety disorders, what level of impairment is it causing? Is it mildly annoying, or is it causing parents to miss work, kids to miss school, a lot of friction in the family? Does this feel like the dysfunction and the impairment from it is pretty high versus mildly annoying is one factor. The other, you guys see hundreds of kids kind of using some of your clinical judgment and experience of, most 6-year-olds I see aren't coming in with this set of symptoms. So this to me feels different than the 6-year-old that's asking mom to check once a night for the monster under their bed. So one, trusting some of your clinical experience based on all of the other 100 patients you've seen. Do most of my kids of X age have this set of symptoms? And also the degree of impairment it's causing in their family and in their life.
Okay, thank you. There's another question about the scared. Um, does scared offer insight for kids and parent, but with a focus on anxiety and depression and ADHD?
So scared just looks at anxiety disorders.
Okay, thank you. Thank you for that clarification. Um, do you weigh picking behaviors heavily when considering diagnosis? Say child answers GAD-7 and scores lower on the lower end, but has consistent skin picking behavior.
Yeah, I think it's definitely a balancing act. The number, while it's a number, it's still somewhat subjective. When I think of the case I presented with the high school basketball player, we're making a lot of progress in today's age, but there is still somewhat of a stigma and a culture for athletes and for males that they might not want to report symptoms or they might need to suck it up. So sometimes you might see, like we did with those two patients I presented, a lower score in somebody who's clinically having more significant anxiety. So take the score as part of your overall assessment. Similarly, like you would take pain as a partial portion of your assessment if you're trying to diagnose something else. It's a part of the picture, but not the whole picture. Also, kind of taking both sides, the parent and the patient, information. Sometimes one or the other might see things very much strongly compared to the other, and really trying to think about that bigger picture. Where is impairment coming in? Parents might be frustrated because they're late to work, so they might voice it higher. Or as kids are noting a lot of distress at school, but they don't act that way as much at home, so the parents might be lower. So kind of really looking at the big picture. The numbers are one piece of things, but if you're seeing a lot of those behaviors, such as fidgeting, skin picking, hair pulling, other things that are like, this sure looks like you're anxious, they're probably anxious.
All right, thank you. Well, we are just right before our time for our next presenter. So this will wrap up the Q&A for this session. Thank you again to Dr. Elliott for a wonderful presentation. And now we will transition to our next presenter. I'm pleased to introduce our next speaker, Dr. Jamie Elizalde. Dr. Elizalde is a licensed child and adolescent psychologist and clinical associate professor with the University of Iowa Department of Psychiatry. She will be presenting on supporting children with anxiety in primary care. Welcome, Dr. Elizalde.
Good morning. Thank you all for joining us this morning. It looks like a really good agenda, and I'm actually going to stay tuned all morning. So, coffee, are my slides visible? Everything okay as far as that goes?
Yes.
Okay, great.
Perfect. Thank you.
Yep, there were some great questions for Dr. Elliott. I also want to thank Dr. Elliott for collaborating with me on this. She covered a lot of really good information about some of the measures that we might use and what to look for. She also mentioned the fact that, as many of you are already aware, most of these children first present to their primary care physician. And so I'm going to spend a little bit of time talking about some of that, but what I really want to focus on is sort of how these things come to be, what anxiety is like, how children experience it, parents' role in that, and then what can you do in a session when you're seeing them for a short period of time. So, with that being said, my slides are quite extensive and they will be made available for you. I'm not going to read everything off the slides, I promise, but it's there for context if you want to go back and dig into something a little bit more in detail. So let me kind of advance my slides here. So again, I really want to help you to understand what anxiety looks like, I'm also going to lump OCD in there to a minor extent because that's something we also see oftentimes. I want you to sort of see how that looks and what it feels like for children and adolescents. Learn about that accommodation cycle. That's something that can be really important to explaining to parents and children what's happening with anxiety and OCD for them. And then some of the non-pharmacologic treatments that we use and best practices and how you might take pieces of those away for your day-to-day clinical practice. So here's the basics. If you can remember these things, you're starting off on the right foot. Anxiety and OCD involve avoidance. They're avoiding things that make people uncomfortable, situations that are distressing. And keep in mind, children may not use these fancy words like, I'm anxious, I feel distressed. So you're going to have to do a little bit of digging to find out what's happening. But generally speaking, avoidance of something and anxiety and OCD are very prominent. That being said, the intervention or the treatment that we go to is approaching these things, moving toward. And again, Dr. Elliott mentioned this is facing your fears, facing the thing that's making you uncomfortable. The key here is that we do this in a gradual manner, and I'll talk a little bit more about what that looks like and means as we go through. So again, Dr. Elliott hit on a lot of these points. So I'm going to go through this section sort of quickly, but we know that anxiety can be healthy and normal. It's adaptive. It can help us to stay safe, clearly, and it improves our attention and problem solving. For children in schools and teens, it motivates you to work hard, to study for tests, to be prepared. And it keeps you safe again in those dangerous situations. There are also levels of anxiety and fears that are normal depending upon developmental age. So we expect younger children to have stranger danger. In fact, it's there for a reason. It's protective for them. We know that as children get a little older, there may be a fear of death. We know that more phobic type behaviors start developing around 5 to 7 years of age. In terms of things that might look like OCD, so that sort of obsessive or compulsive behaviors, we know that young kids have routines at bedtime. In fact, as parents, we encourage those so that things remain predictable and consistent. There can be magical thinking when kids are younger. So we want to be careful not to confuse developmental trajectories with anxieties and OCD. On the other side of that, just to make things really confusing for you, children don't often recognize that they have anxiety or OCD. It may be the parents first that are seeing these behaviors because they don't have the insight, particularly under about age 9. So just something to keep in mind on the other side of the developmental expectations. So Dr. Elliott went over these in some detail, but when we talk about anxiety disorders, these are the ones that we're really referring to that develop during childhood. Again, anxiety is one of the most common childhood disorders. When we look across these as a whole, about a third of people by the age of 18 will have met criteria for at least one anxiety disorder. We also know having one anxiety disorder makes it more likely you'll have another. So if as a clinician you feel confused because you're not sure what you're looking at, that probably makes sense. They don't just come neatly packaged. So generally speaking, the way that these occur is we see separation anxiety more for younger children. We see social anxiety developing later in the school age years and early adolescence. And then we see more of the generalized anxiety in later adolescence and young adulthood. Again, those are not firm rules, but that's sort of what you might see across the board as children are coming into clinic with you. In terms of OCD, first of all, I want to say it's not even classified as an anxiety disorder anymore. It used to be. So that's an important piece. On the other hand, we know that a lot of the things that happen with OCD are distressing and create anxiety. So I wanted to be sure to mention it. We also know that the diagnosis is made later, and so that means treatment is started later. So if you notice some of these things, you might be able to help somebody to sort of get pointed in the right direction a little sooner. So OCD is having these obsessions, so these recurrent persistent thoughts, urges, or images. So it could just be a picture. It may not even be words, and these cause distress or anxiety. So this isn't the child who likes to play video games all the time. That's not causing distress to the child. They're actually enjoying it. They're having fun. A child who talks repeatedly about going to do a certain event, if it's something they're looking forward to and it's not causing marked distress or anxiety, that's not an obsessive behavior related to what we would consider OCD. And in fact, these obsessions are so distressing that there are great attempts to suppress them, ignore them, or do something to neutralize them. And the neutralizing part is what we call the compulsion. So the compulsion is a repetitive behavior or mental act that somebody feels like they need to do because of that obsessive thought or image that pops up in their mind. And usually there's some pretty strict rules they have to follow in order to do what they consider neutralizing for that obsessive thought or image. And again, these compulsions are aimed at preventing or reducing the anxiety or distress. And as I mentioned earlier, from a developmental standpoint, younger children might not be able to explain why they're doing these behaviors or what these mental acts are. They may not realize other people don't have these things that they have happening for them. So generally speaking, these are the categories that we typically see for the obsession. So the thoughts or images that pop up for people, and then also the compulsive behaviors. These are not a one-to-one alignment. So when you look at this, it's not that people who are aggressive do exactly what's across in the compulsion category, but just kind of to give you a general understanding. And I do have resources at the end, and there's a great website, the IOCDF, the International OCD Foundation, and they have multiple handouts and information for providers, for parents, and for the children themselves that will give you a lot more information on these if it's something you're wondering about or concerned might be happening. So let's talk a little bit about the impact on daily functioning. What does anxiety and OCD do? What does it feel like? First of all, I think if I gave you a moment to pause, we can all think of a time that anxiety or something uncomfortable, a thought or image has gotten stuck in our mind. That alone is not unusual. What makes it more related to the problematic side of things, what brings people in to see you, is the response they have to that, the doubt, the discomfort, or the avoidance that interferes with daily functioning. But if for just a minute you can kind of think of a time that something was very distressing to you, and we're going to kind of walk through what happens. It's kind of like this. You're out for a walk in the woods, everything is nice. You're feeling good about life. Maybe you're with a friend, maybe alone, whatever brings you the greatest sense of peace and joy. And all of a sudden, you see this guy, and you're going to have a reaction. And that's a good thing because that's anxiety or fear keeping you safe. And so what happens in your body is we go from this rest and digest system to the fight, flight, or freeze response. And again, in this situation, I hope you have that response. That's protective. It's why we have this. And so again, understanding this and being able to articulate this for children and families who are going through this can be really helpful so that they understand this is something people have in general, and we were given this ability to feel fear and anxiety for a reason. The problem is that for people who have more of an anxiety disorder that's getting in the way of their day-to-day life, their body is tricking them. So they think they see this cougar, all of those physiological responses kick in, that fight, flight, or freeze reaction, because this is what they see in front of them. But actually, it's this. And they either, because of anxiety, doubt, previous experiences, don't recognize this. And by the time they see that it's a kitty, all of those systems are already in full gear, and it's pretty hard to shut them down. And so now maybe they don't want to go for a walk in the woods anymore because they don't know what they might see, and they can't risk having that happen again. And that's how that avoidance cycle starts. So just to kind of bring this point home a little bit more, anxiety is like a false alarm. It is the alarm that rings and everybody exits the building, or everybody kind of gets a little anxious, and then we leave. And then we find out actually there was no fire, the alarm isn't working. But the next time it goes off, it could be the real thing. And responding to that false alarm time after time is exhausting. And that's sort of what this next slide is to help us to remember, is what we might see or what might be reported to us about somebody with anxiety or OCD. They're constantly scanning for danger. They're constantly getting false alarms. and they're trying to control all of these different variables so they don't get put into that place again where they have the fight, flight, or freeze reaction. Surprises are not good. Uncertainty is not good. And this is an exhausting process. So let's talk a little bit about more, I guess, about what that looks like in terms of functional impairment. Again, Dr. Elliott did a great job of saying, yes, the screening tools we use are really helpful, but also how is it getting in the way of their day-to-day life? And we can usually think of this in terms of the fight, flight, or freeze response, and that sort of corresponds to the behaviors or the reports we might get from schools or from parents. So in medical appointments, you're going to have a lot of them for illness and concerns. You might find yourself seeing the same parent and child on more than one occasion and reassuring them that in fact there's no known cause for the stomach aches. And you might even suspect or have said to them, is this something that maybe is happening because you're feeling nervous or worried? So you might see that. You will see a lot of other sort of medical symptoms that come up in addition to that. So there may be headaches, there may be abdominal migraines or pain, there may be nausea. You may get medical questions. Is it okay that this happened? Are you sure it's not going to get infected? When do we need to come back again? My mom doesn't believe that. So these are the sorts of things you're probably already familiar with. There are sleep problems. Again, if you go back to what we were just talking about with trying to control all of the variables so that nothing is unpredictable, scanning the environment on a constant basis so you don't end up in that fight, flight, or freeze, or ending up there repeatedly, all of those take their toll and they lead to sleep problems and difficulties and more fatigue. So we also want to recognize that sometimes what is anxiety may look like inattention, impulsivity, hyperactivity. It can look like other disorders. It might look like ADHD. There may be difficulties with eating. And one thing that we know that I find kind of interesting is that there's a medical comorbidity. So people who have gastrointestinal difficulties or migraines or asthma or skin conditions, there's this sort of synergistic interaction. So if they also run anxious, then the symptoms of their medical condition seem to somehow be increased over what we might see in someone that has the medical condition and doesn't have a form of anxiety that's comorbid with it. So what we might hear from parents or teachers is they're not going to school, or they're going but they're showing up late. They go to school but they're not doing their work, or they're staring off and we don't know what's actually happening. We know they can do the work and they're not doing it. We know that they're smart, but they're not turning in all of the work, or some days are good, some days are bad. It doesn't seem like they're remembering what they learn. So these are some things we might see, and executive functioning takes a hit. And again, go back to thinking about scanning your environment, being on guard. So children who have a phobia of storms, if they come into the building in the morning and it was overcast, they may be sitting there thinking about what are they going to do if there is a storm? Where will they go? Did it start storming? What if there's a flood? So they're not learning and they're not recalling because they're not taking the information in. It may also make them look inconsistent in their performance. So there may also be a lot of visits to the school nurse, and they may have the same sorts of questions for the school nurses as you may be hearing in session. They may have disciplinary referrals because we know that there can be some sort of oppositional or aggressive behavior that comes with anxiety from the fight part of that fight, flight, or freeze. At school, or I'm sorry, I think I got ahead of myself here. At school, some things that might be happening in addition that you may hear about are ADHD, and you certainly want to look at that. Dr. Elliott brought up a good example of how they may overlap, and we want to take a look at that, but also be aware of what may be related to anxious behaviors. In terms of social functioning, there's also a pretty significant impact, and that can be impairing. So children and adults too, who have anxiety or OCD may avoid peer interactions because those are situations, again, that we can't really control fully, and uncertainty is sort of a big part of anxiety, and so it may be difficult. If there are a lot of rituals that are happening and those are time consuming, then you may not make it to places to actually see your friends, or you may not want to go because you know it's going to involve more rituals in order to get yourself there or when you leave. It is embarrassing. And so that's another reason that people may avoid social interactions. So there may be a decrease in the sorts of activities that they're engaged in. They may actually refuse to participate in certain events or activities, and they may appear less confident. So there is this cycle that happens. There's actually a few of them, and I want to sort of go through those. And again, this is something that when you learn that a child has an anxiety disorder or OCD, this psychoeducational component can be very helpful because it helps to normalize what the process of anxiety and OCD are, and it makes it a little bit less like a myth. It kind of demystifies what's going on. So, first of all, the way that I explain it to children is that anxiety is sort of like a monster. It works well when it does what we need it to. And I give some examples like we had previous about keeping you safe. Um, but if it's something that we're not really in danger from, we're feeding the monster. And what we're likely to see is that the frequency of the anxious behavior or the obsessive compulsive behaviors may go up, the intensity, so how strong the reaction or urge is, goes up, and the length of time, how long it takes to kind of calm back down from that, goes up. So every time we sort of give in to what the anxiety or OCD wants us to do, we sort of reinforce it. So this is what that might look like in anxiety. So at the top, the red circle is the trigger. Something happens that triggers anxiety. So let's say it is giving a speech. You find out you have to give a speech at school. Anxiety goes up. The instant reaction, the instinct, just like it would be in any anxious situation, is I'm not going to go. I have to avoid this, maybe leave the classroom. And as soon as we get away from that thing, that anxious thing that was triggered, anxiety goes down. And so, whether or not it's at a conscious level, we learn that avoiding things that make us anxious, that trigger that anxiety, it works. Unfortunately, it only works in the short term. There are long-term consequences for this. And again, it sort of reinforces that cycle and feeds the monster. A very similar cycle happens in OCD. So something triggers an OCD type reaction. Let's say it is a sticky substance on somebody's hands. So they're at school and someone left glue or something on the table and they touch it, and the level of distress goes up just dramatically. And the thoughts possibly that go along with that, or the discomfort from that sticky substance and what it might mean, increase. And so the person's reaction is a compulsion or a ritual. So maybe it's hand washing. And as soon as they do that, the anxiety goes down. And so again, there's that sort of message. As soon as I do that compulsive behavior or that ritual, this distressing situation leaves me. We also call that neutralizer, right? Engaging in the behavior. Unfortunately, it's only short term. So next time the hand washing may have to be longer, or it may be more precise, or then the types of things that are sticky substances starts to grow and generalize to other areas and places that maybe they're not even can't even believe it's related. So those are how these cycles build. And this is how I describe it to parents and children, as feeding that monster of OCD or anxiety. So let's talk about how we break that cycle. How do we defeat the monster? And I'm going to talk about best practices. And Dr. Elliott mentioned this. So this is, again, the non-medicine treatment. And the best treatment that we have is cognitive behavioral therapy, in this case, a very specific kind, which is exposure therapy for anxiety or exposure response prevention for OCD. What you'll see here are the basic steps that are consistent across different programs, whether they're manualized or something that has been done in a research trial. These are the typical steps or components that are involved. And what you'll notice is that number 4, the gradual exposure, is bolded. And it's because that is the key ingredient. That's the active ingredient that we know leads to better outcomes when we use this form of therapy. So this is important. Dr. Elliott mentioned that we have to avoid avoiding, right? We know that if a child is not going to school, the most important thing is to help them to start getting back to school, or that monster grows. So let's take a look at what this cycle looks like. So in exposure, what we're doing is something triggers it. So again, that sticky substance, perhaps, anxiety increases, and we don't allow the person to engage in the ritual. So there's a preventing that response. That's where the phrase response prevention comes in. And what the person learns over time is even if they don't wash their hands a number of times, the anxiety decreases. And they learn that they can handle the situation, the feeling. It will pass. And this sounds easy. Intellectually, it makes sense. It's very difficult. So I don't want to oversimplify it, but this is generally speaking how exposure and response prevention works. In an anxiety-provoking situation, what we would do is something triggers anxiety. So let's use the example of a child going to school. That their parents get them up, they drive to school. As soon as they see that front door and all the kids, their anxiety goes up. So their instinct is to not get out of the car, to refuse to go to school, to go back home. And as soon as the parent turns the car around, their anxiety goes down. When we're using exposure, the parent actually goes to the school. Maybe they just sit and wait for a while until the child says, "Oh, I guess my anxiety went down even though we didn't go home," right? So this is where the gradual piece comes in. And I have an example here using giving a presentation to the class. So with exposure, again, we're doing the opposite of what OCD or fear tells them to do, and that's them fighting the monster. And not for every child, but I would say for a majority, that can be a really powerful metaphor. I tell kids this is the one time you get to break the rules. When you listen to anxiety or OCD, don't follow the rules. And whenever you're not following those rules, you're fighting back. So the gradual part of this looks something like this. This is what we call building a hierarchy. You may have heard SUDS, which stands for subjective units of distress, which is actually asking them, what is the most scary thing that you can imagine? Well, it's actually getting up there and giving that presentation. It's actually having my hands filled with honey or something sticky and not being able to wash them right away. What's a situation that is not as scary down here at the bottom, what would be a 1 for you? So in this case, instead of giving the presentation to the whole class, maybe it's reading the presentation in your mind. So what we're doing is we're building this hierarchy and we're looking for things here in this middle range. I call this the sweet spot. This is where we start the exposures. So we're not going to say you have to get up and give that speech. We're also not going to say, you know what, that's fine. You don't have to go to school and ever do it. We want to challenge it a little bit. And typically, once children understand we're not going to force them to do the impossible or what feels like the impossible, and they understand that there's something going on, and that they can work to defeat it, they're willing to sort of work through these steps with you. So that's one approach. And here's the other approach that we talk about in terms of an accommodation cycle. So this is what happens when parents sort of get involved in a child's OCD or anxiety. So here's an example where the child is told, go get your backpack. And the child has the thought, well, I'm afraid to go get my backpack. I can't do this. And so the parent goes with the child to get the backpack. And as soon as the parent is with the child and they have the backpack, their distress goes down, their anxiety kind of goes away. And then they have this thought, again, whether it's at a conscious level or not, well, the only way I can get things out of my room is if somebody is with me, mom or dad. And then this grows. Parent continues to go with them, and the places and the things that they can do without their parent present tends to pick up. It tends to get greater. So this one-time shot ends up being a multiple time experience. So what we do in this case is we work to break those accommodations by helping parents and the child to see what's happening. So a caregiver accommodation is any action that a caregiver may be doing, or even things that they're purposely not doing, so because of their child's anxiety. So we want to help them to break this cycle. To be clear, most people who have children or adolescents with anxiety do something to accommodate. So this is not something that people do that is easy to stop doing. It's also not something people see that's developing. It's very insidious. It starts with protecting them from stranger danger, and then it just sort of pours over into other areas. And if they're concerned about their child's safety or well-being, or if their child is aggressive, or if they have certain things they need to accomplish on time frames in the morning, for example, like their own job, you can see why accommodation starts to happen. And what nobody really recognizes at that point is that it actually picks up if it's more based in a disorder. So what we do in this case is something called supportive parenting for anxious childhood emotions. This is a program that works with parents to understand this cycle, recognize what accommodations they're making, and work to slowly back out of making those accommodations, but still providing support to their child and validating their child's experience of anxiety or OCD. So this is what this looks like. And this is just the first step in the program, but it's an important one. It's accepting their child's emotional experience. So I know that it feels scary. I can see that it's really hard for you. We're not denying that part. We're also giving them a vote of confidence. I know you can cope and face this challenge. We're not saying it's going to be easy. We're not saying you're going to have 100% success. We're saying I know you can handle that scary feeling. And Dr. Leibowitz, who wrote this book here and who developed this program, he calls this the mac and cheese. You need both pieces of this to provide your child with support. So clinical applications, this is a really critical part. I've already been hopefully giving you some information as you go along. And one of those is you can provide some of that psychoeducational information to families and children and adolescents about the cycle of anxiety or OCD and how it develops. The other thing that you can do is provide recommendations that include what we know to be the most effective right now, which is cognitive behavioral therapy with exposure for anxiety or exposure and response or ritual prevention for OCD. You can also recommend space for the parents. And I know that there are wait lists, and I've heard some of you say that, which I can absolutely appreciate. We are on the other end of those, hoping and wishing we could serve more people. I know Dr. Stevens and Liz Gleason from the Scanlon Center are going to talk a little bit about some resources toward the end. But again, I have provided at the end of the presentation a number of websites that have information and also some that have programs that parents can walk through with their child. So there may be some who have a milder case of anxiety that can do some of those steps on their own. But again, what you can do is that first step of providing information about what anxiety and OCD are, and that it's something we all have, that anxious response and what it does for us, and those accommodation cycles. You can also use these supportive statements. These, again, I want to be clear, these are only the starting point of the entire SPACE program, but they're also the starting point, which means they're a foundational skill. What they do is they take parents and us as adults and caregivers for people with anxiety, is it moves us from this place of either protecting them from their fears or being too demanding and saying, like, you just need to get out there and do it. It moves us to this place of support. So we're sort of having this acceptance or validation, and we're also providing them a vote of confidence. So in a visit, this might look like, I know that getting shots is a really scary thing. It makes a lot of us scared, and I know you can handle that big feeling. And modeling that for parents too, who may have a different narrative going through their minds. So this is something you might just take and kind of keep with you. You can also recommend the book to parents. And then another thing that you can do right in session, if it's a milder case again, is to start thinking about ways that the child can approach a situation gradually. If you have the luxury of actually giving them an example like this, and I say that because I understand time is limited, you can maybe help them to see that there's this middle ground. I've had a number of parents and children who they don't want to be in this situation. And once they understand, and you can give them just even a middle piece and the anchors at the top and bottom, they leave with an idea of, okay, I know that going all the way into school today is a 10. What can we do that's a little bit harder than what you're doing right now? And start to collaborate with their child. Another thing that you can do in session is use labeled praise. You can tell parents to do this. Highlight situations where the child has been brave. They need to recognize times they have fought back against that anxious feeling, and that they have that skill that you can feel anxious and still do hard things. So recognize those courageous actions. I often start sessions by asking the children and teens, what's something you did to fight your OCD or your anxiety since I saw you last? And that's their chance to really think and recognize there are things they've done. They can do these hard things. Watch out for your own accommodating behavior and language. It is a really slippery slope. Parents aren't the only ones that accommodate. We do it too. I find myself doing it. There's a lot of reassurance seeking questions. So you're telling me I'm going to be okay. This isn't going to happen again. This isn't fatal. It's going to be fine. You don't see anything bad. These are, of course, things that you should answer. And if you know the child knows the answer to the question, or if it's something you can't actually answer because it's not definitive, you kind of want to say, I understand this is hard because you don't know, and I know you can handle that feeling. So you're kind of going back to those supportive statements. If you make decisions for a child who can't decide what they want to do in any given situation, they're going to look to you to make the choice for them the next time. And that's how that accommodation cycle starts. So you kind of want to say, well, what do you want to do? No, I know you can pick, and try to find that sweet spot again in the middle where it's something they can choose. Maybe it's choosing between two things instead of an open-ended question. But don't find yourself in that cycle where they're asking you for reassurance or to answer questions or make decisions. And other rituals, we want to watch for engaging in those too. Last thing before I turn it over for questions, in terms of providers who are working in primary care, you do have the opportunity to support and write information that schools can take into consideration for IEPs and 504 plans. Schools make the decisions about the level of impairment that's happening in that setting, so they're the ones that will ultimately decide whether an IEP or 504 plan is necessary. But ways that you can support it is by maybe providing them information about things that you know may be happening for the child and where they may need some accommodations. In this regard, accommodating is okay as long as we're not overprotecting them. And that's another piece of this to stress to parents and to schools. A child who gets to work from home because of anxiety, that's feeding the monster. We kind of need to be working on a plan to get them back in simultaneously. There are great recommendations for 504s and IEPs, again, on the websites that I have listed at the end of my handout. And these have to be collaborative for the reasons I was just talking about. Parents and children may have things that they know are happening that schools may not be aware of, or that primary care doctors aren't aware of. And so we have to sort of find a way to collaborate and keep the lines of communication open, because those accommodations need to be thought of as a living and breathing experience that's going to change over time. So I'm going to stop there. There's a couple more handouts here, and then the resources, which include some of the books that I talked about and some other ones you might provide to children or parents. So thank you.
Thank you so much, Dr. Elizalde. There were some great recommendations you shared that I'm sure providers will be incorporating into their clinics. We'll dive right into questions. One question that was submitted was, what are the best ways for providers to work with therapists?
That's a really good question. I think one on both sides, we can probably appreciate that timing is really condensed. And if parents understand the importances of us working together, I think just even a quick phone call to establish the basics, and then following up by confidential messaging if that's an option. So if providers are all in the same medical chart, that can be a way to do that. So that's something, again, I'm very grateful. I'm in the Department of Psychiatry, so I can step out and check in with providers and just say, hey, here's the things I learned this week in therapy. So in case you get this question, or can you help me with this when you talk to parents next? So once kind of the foundation is laid for any certain case, it's easier to continue to build on it without that extensive time that might need to happen in the beginning.
Thank you. What do you recommend when students are having anxiety, stomach aches, and they may complain about that on a regular basis?
Yeah, so I'm not sure where that question is coming from, if it's coming from an educator or a school setting or from a medical setting. If it's coming from primary care, which I'm gonna go to that since that was the topic for today. I think once you as the provider has ruled out any sort of underlying medical concern, then it's recognizing and going back to explaining that cycle of anxiety and how anxiety creates for all of us this feeling of fight, flight, or freeze, that going through what happens in our bodies when adrenaline starts pumping and why our stomachs might hurt or why we have butterflies in our stomachs or lumps in our throats. So again, normalizing that that's an experience we all have. And then sort of maybe helping them to recognize that theirs extends beyond that. And providing them with resources that help calm down the physiological symptoms, so guided breathing, helping them to and their parents to use those supportive statements. I know it feels scary. I know your stomach hurts, and I know you can handle whatever it is that they're avoiding because of the stomach ache.
Thank you.
Mhm.
Um, do you have suggestions for therapy alternatives for a family that either doesn't have access, maybe financial distance or insurance, or time for therapy? Are there books or apps or other things you would recommend?
Yeah, so again, I have a lot of those at the end of my presentation. I think those will be really helpful. And some of them you're going to have to dive into a little bit. But for example, this is a website that discusses anxiety in the classroom in a lot of detail. And it even has presentations that people can give or look at. This is a website that has, and these are all free materials, and it actually has information for parents and it shows them how to lay out a plan and how to build a fear hierarchy with their child. And this is one that is geared more toward providers, therapists, counselors, and schools, but it has a lot of materials. And if you are a provider in a clinical setting providing primary care and you have the opportunity to print some of those handouts out for families, that would be an option as well. There are a lot of apps. The thing about the apps, and it looks like this might have happened when I recommended the Spence anxiety scale for children earlier, is that they change and become paid apps at some point, and I have trouble keeping up. And so, unless I know specifically that something isn't going to charge a family once they've already gotten into it, I'm a little cautious about it. But some of the ones that the VA has developed are appropriate for older children, and they will walk through some of these same steps that are evidence-based for anxiety and OCD.
Okay, thank you. Um, what evidence-based, you talked about different recommendations that primary care can do in their clinic, but are there evidence-based interventions that can be initiated in primary care settings for mild to moderate anxiety?
So some of the things that I was just talking about are some of the steps that you could take. I don't know how much time you have when you ask that question. There are some studies out there that point to 8 sessions for milder anxiety, and I believe also for depression that can be done in a primary care setting, but that's assuming that you have the opportunity to provide 8 sessions. But they follow that same model that I pointed out earlier, and I'm going to kind of go back to that slide that uses what we know is evidence-based. So it sort of looks at these basic pieces. So whatever program you would look at, you want to make sure it has these pieces to it. But the key is to eventually help the person either to begin doing exposures on their own or understand that just talking about it isn't always going to lead to the change. You have to engage in that piece of it.
Okay, thank you. Well, it looks like we are just approaching break, so thank you so much for a great discussion. I want to thank everyone for the great questions, and another thank you to Dr. Elizalde for a wonderful talk, very informative. Um, and we'll be sure to, I know there's questions about the slides, and we will be getting the handouts after the conference. Well, thank you again, Dr.
Thank you.
Elizalde. Thank you. Okay, so we will now take a 15-minute break um, before the next presentations. And so everyone enjoy your break, and we will see you back here at 9:40. Well, welcome back, everyone. I'm excited to introduce our next presenter, Dr. Michaeline Jensen. Dr. Jensen is a licensed psychologist and associate professor of psychology at University of North Carolina, Greensboro. Her presentation will address support for youth and families in the digital age. Welcome, Dr. Jensen.
Thank you for having me. I'm happy to be here. Hello, everyone. So as you just heard, I'll be talking to you all today a little bit about young people and their digital lives and how practitioners and parents can best support them kind of in an increasingly digital age. So we're going to cover a lot of ground. I know we don't have a ton of time, but I think we can get a lot done here today. So we're going to talk a little bit about the research evidence base for what we know about how technology engagement is related to youth mental health and what we don't know. We'll talk a little bit about the limitations of some of the prior research and some really exciting newer research, which is more nuanced and perhaps the most useful in helping us craft digital worlds that allow youth to flourish. And then at the end, one of the ways that we can do that is by helping parents parent around technology. And so I'll share some tips for how that can be done most effectively and how practitioners can help facilitate parents engaging in that work. I don't have any conflicts of interest to disclose. So as I'm sure all of you know, young people are very online. Nearly all adolescents in the US today have a smartphone, and that is across race, ethnicity, socioeconomic status, any dimension of difference. Most teenagers have a smartphone. And indeed, they're spending a lot of time on those smartphones and on the internet via other devices like computers or laptops. So almost half of teens say that they're online almost constantly, and that's quite an increase from only a decade ago. And what app is the most popular at any given moment shifts around a lot. But right now we know that youth are spending a lot of time on YouTube in particular, but also other popular social media apps like TikTok and Instagram. So that brings us to the question that I'm sure you all have asked yourselves, you've seen in the media. Are smartphones and social media harming youth mental health? And indeed, this is all over the news. You can't turn on your computer or scroll the news app without seeing a headline about how usually young people's online engagement might be harmful. The Surgeon General brought attention to this topic. But the headlines, I think, often obscure some of the nuance of what the research has actually shown in this space. So I'm going to spend a couple of slides here kind of giving us the lay of the land of what the evidence base is on this topic. And I do want to acknowledge that there's actually quite a bit of controversy in this space. So on the one hand, you have folks who argue quite strongly that young people's social media engagement and technology use is driving the current youth mental health crisis. So increased rates of anxiety and depression and suicidality that we're currently seeing in adolescents and young adults. On the other hand, you have folks who say, I mean, we're worried about youth mental health, but this moral panic over social media in particular is perhaps not warranted and might be characteristic of other moral panics that we've seen around other novel technologies and ways that youth spend their time in the past. So let's talk first about that first argument, that technology engagement might be driving youth mental health. I'm sure you all have seen a graph like this. Oftentimes this argument is really scaffolded and supported by folks who say, look, we can see that mental health is getting worse over historical time. So here on this graph, you can see that since the early 2000s, we're charting, this one is emergency room admissions for self-harm behaviors, which is nice because it's an objective indicator that does not include self-report of mental health symptoms, which is one of the potential confounds when we're thinking about changing rates over historical time in mental health symptoms. And so here you can see that over the past 20 years, emergency room admissions for self-harm behaviors among girls and young women who are particularly at risk have gone up. And oftentimes folks will draw a line around that kind of 2010 period when the iPhone began to proliferate and say that's when we really see the increase, and ergo, that's the cause that young people's worsening mental health must be due to smartphones and social media engagement. That argument is not without its critics. Some folks argue about whether or not there even is a youth mental health crisis, and they do make arguments around things like reduced stigma around reporting mental health difficulties, which is happening. Diagnostic criteria changes. But overall, I think we don't have to agree, actually, that the rise is this stark. At least from where I sit, youth are struggling today, and we should be trying to figure that out. And if social media is playing a role, we should try and understand that so we can help prevent it. So the other camp talks about how everything that young people do has over historical time tended to provoke panic in us adults, that young people are usually the earliest and most enthusiastic adopters of new technologies and just new forms of entertainment. Young people are adventurous and willing to try new things. And so you see here some quite old headlines mixed in with some newer ones about moral panics that arose in the past around things like Walkman, so portable music that you could take with you, and how it might be altering minds. But then also books and penny novels and comic books, and video games was a more recent moral panic that arose. And we can think about the ways that the current hullabaloo over young people's social media engagement may parallel these prior moral panics, in that they are older people getting upset about the ways that young people are choosing to spend their time. And so Orban published a paper in 2020 that talked about this as a potential Sisyphean cycle of technology panics. And Orban talked about the fact that panics will be created and that they arise when there's a new technology that young people are getting excited about. And that often this panic is taken up by politicians and kind of thought leaders, folks who have a lot of loud voices who are heard far and wide. But the solutions and the search for evidence is often outsourced to scientists, who we all actually are quite motivated to solve these problems. And if there's a problem there, we want to understand it. This sometimes results in what Orban calls wheel reinvention. So we're kind of asking the same questions again in a new way. Often we don't make much progress in this research. We don't end up concluding that the technology is currently ruining young people's lives. So we're all still reading novels. Clearly, we moved past that technology panic or that media panic. And then a new technology arises and we kind of move on. We might be seeing that a little bit with AI. So social media is getting less attention and AI is now sucking up more of the air in the room. And we might be seeing evidence of kind of the trend yet again of a technology panic. So folks are a little split here. So is there any consensus? There is. And I'm going to share with you kind of what that is and what the scientists have tended to conclude. So I'm putting here a few of the most rigorous meta-analyses and review papers that have tackled this question. The National Academies convened a panel to ask this question. And indeed, we do have some consensus. And the consensus tends to be that social media and smartphone engagement is not robustly linked to population level mental health risks. And what I mean by that here is not that for no child is social media causing difficulties. That certainly is true. But when we look at the aggregate at the population level, it does not appear to be that youth mental health difficulties like depression, anxiety, self-harm, suicidality are primarily caused by the ways in which they're engaging on technology, at least not the amount. So a lot of this research has flaws. So I talk here about quality issues. The vast majority of studies have relied on really overly broad, crude metrics of self-reported screen time. I don't know if any of you have ever tried to estimate your screen time without the help of the app that's on your phone. Humans are just really bad at this. We are bad at knowing how much time we spend doing different activities, especially if that activity is one that starts and stops, like technology engagement. It's also a flaw that a lot of the studies in this space are cross-sectional. So even when significant associations do emerge, say between depression and screen time, we don't actually know what's driving the bus there. It could be, as many posit, that the amount of time that young people are spending on screens or social media is causing them to be more depressed. But it's also possible that young people who are struggling with anhedonia and low mood and lack of motivation that are characteristic of a depression might be spending more time on screens. And cross-sectional studies can't tell us that answer. Overall, I will say though, when we meta-analyze the studies that exist in this space, there tends to be quite mixed results. It's a mix of small negative, small positive, and mostly null findings. And this contributes to that conclusion that it doesn't seem like young people's technology engagement, especially screen time, is the driving force behind mental health problems in adolescents today. I do think, though, that more research that is nuanced, I'll talk about in the next few slides, is telling us a little bit more about how we can learn from within person questions. So looking at individual teens and how their mood fluctuates on days that they use more technology or less, that's useful, rather than doing between person comparisons, comparing some teens who use more technology to others. And then also increasingly, we're trying to understand the heterogeneity in young people. So how different features of technology may impart different risks and potential benefits, and how different teens who bring to the table a whole host of risk and protective factors might see different technology use effects. I've done some of this work myself. So we collected a sample of about 2,000 early adolescents from all over the state of North Carolina who were diverse on race, ethnicity, socioeconomic status, importantly, rural urban characteristics, because a lot of features of screen time can vary based on rurality. And we followed up with about 388 of them a couple years later in an intensive longitudinal design where we asked them questions several times a day over 14 days about the ways that they were engaging on technology, what they were using it for, and how they were feeling. Our research was one of many other studies that has tended to have mostly null findings. So we did not find that any of the ways that we tried to operationalize technology engagement, so that was self-reported technology use for texting, entertainment, creating content, schoolwork, we thought that some of these might be beneficial and some of these might be more detrimental. On average, they were not particularly associated with conduct problems, inattention or hyperactivity symptoms, worry, or depressive symptoms. And we also didn't find particularly strong evidence of moderation by person level characteristics or nonlinear or next day effects. So this is just to go show I've contributed to this literature, but I think on average, the consensus has tended to be that screen time is not the place we should be looking. And it doesn't appear that that is the driver of young people's mental health problems. Okay, so what do we know? And what would be the point of knowing more? Where should we look? So I think increasingly there's consensus that we need to be understanding how distinct features, affordances, and types of technology engagement impact mental health. So really recently was a really lovely annual research review published by Mayhew and Burnell and colleagues in the Journal of Child Psychology and Psychiatry, where they started to delve into this. And they were talking about the different components, that's features, affordances, types of use that might be imparting risk, and indeed those that might be imparting potential mental health benefits. And so here you'll see, I'll go into some of the different features that we could be thinking of. So to illustrate this for you, filters, a photo filter. This is a common technology that young people and adults are employing on apps like Snapchat or Instagram, or even on your Zoom where you can put on a filter. And so these are effects that change the appearance of photos or videos. Common Sense Media did a really neat survey a couple of years ago where they asked teenage girls how they perceived the ways in which these different features might be impacting them. And so here for filters, you'll see that about 21% of girls said that they felt that these had a predominantly negative impact, citing examples like body image concerns and becoming overly focused on their physical appearance. On the other hand, 38% of girls said that they predominantly saw these as a positive thing and that they enhanced their experiences online. They said that they were fun and entertaining. They were a means for self-expression. And so you see here, there's no consensus between young people about how these are impacting them. But it does highlight some of the ways in which we might be studying these types of features like filters to understand young people's experiences. Another example is endless scrolling. So currently, the majority of social media platforms don't end. So if you're on there and you open up your Instagram or your Facebook or your Snapchat feed or your TikTok, and you can scroll and see what's up and what people are doing. When I was a young person and Facebook just came out, there was an end to that. It would say basically like, oh, you've seen it all. You've seen everything your friends have posted, and that would be it. And you would stop looking. That doesn't happen anymore. Now you can scroll forever. The algorithms will feed you new content. They will give you an endless feed of videos and posts, often short form videos that are easy, bite-sized to consume for a long time. So a lot of girls, 26%, say that they do not like this feature, that they think it mostly has a negative impact on them, predominantly because they feel like it contributes to a feeling of addiction or overuse, having a hard time putting it down. And so girls say that this is particularly a problem for sleep. So if they're scrolling at bedtime, it's likely that they're going to stay on there longer than they had intended and lose sleep because of it. 27% of girls, though, say they like it. They think that endless scrolling has a predominantly positive impact on them, citing reasons like it helps them discover new content relevant to their interests, often saying that it helps them find and connect with identity affirming content. And then there's the other half of girls say that it's neither here nor there. They feel like it has a neutral impact on them. And then the third feature I'm going to highlight here is private messaging. I will admit that I'm particularly interested in this feature of online engagement because a lot of my research focuses on text message content. So the ways that young people engage with their peer networks and their parents via private messaging. This one has a predominantly perceived positive impact. So 45% of girls in this Common Sense survey or Common Sense Media survey said that they thought that private messaging mostly had a positive impact on their experience online. And they really cited social connection as being facilitated by the ability to send a private message, say via text or iMessage or a DM, to their social networks. A small minority of girls said that they perceived it as having a negative impact, and the predominant driver of those negative perceptions seems to be unwanted contact in private messages by strangers. So I think I've painted a bit of a picture here that there's different things that platforms can build in or not that might be more helpful or more harmful for young people. It's also important to remember that different features and affordances and components can be uniquely associated with different outcomes. So we shouldn't assume that all dimensions of well-being are the same. So my kind of favorite dimension of well-being when I'm thinking about potential harms of online engagement is sleep. So there's a mixed literature on plenty of pieces about this, but sleep is not. We know that young people's digital and technology use does interfere with sleep, and sleep is really important, especially in adolescence when young people are undergoing rapid development, brain development, executive functions. So for instance, in this Common Sense Media survey, they found that 41% of teens said that they felt like that TikTok was getting in the way of their sleep, and similarly high levels of interference for some other platforms. So the next thing that we should be asking ourselves is, who is most at risk then? If we don't see broad population level harms, that does not mean that there aren't subgroups of kids who are seeing harms and that we should be worried about uniquely. So the most robust evidence that we have there is that there are some groups of kids who we should be more worried about in terms of their technology engagement. Those young people who are engaging on social media predominantly for social comparison. So maybe young people who go online with pre-existing body image concerns and are doing a lot of social comparison, especially image-based physical comparisons. That can, especially if so that's a feature. So their ability to do these visual, so very image-based platforms, and then also an individual difference, a risk factor. That tends to be a not so good for kids combination. Young people who are being cyberbullied or cyber victimized, discriminated against based on their identities online, that's not good for mental health. And then we also find that youth who are somehow vulnerable in their offline lives may be uniquely susceptible to risk in online spaces. So say youth who maybe have social deficits and they have negative online experiences that could be risky. And then we also see some evidence of developmental susceptibility. So Orban and colleagues in 2022 published a paper suggesting that kind of corridors, windows of enhanced risk to online experiences. And it seems like there might be something special about early adolescence and early adulthood. So transition periods, perhaps. This is an illustration of what I was talking about here. So you'll see here on this slide that the socially vulnerable, so those young people who are in some way more at risk for social deficits, so maybe they have social skills deficits. They are more likely to report focusing a lot on metrics like likes and views and followers. And it may be that is importing more risk for, say, depression. Okay, so I've shared a little bit about the research. Where should we go from here? What I want you to walk away from this part of the presentation with is that youth are struggling. So mental health concerns levels are high among young people. Have they risen over historical time? It seems like it, but even if it hasn't been as drastic a rise as it appears to be on some of those graphs, they still are struggling now, and we should be seeking evidence-based solutions to those problems. I do think that we're at a unique moment where we are having better methods to ask these questions and to answer them. We can observe what young people are doing online using things like digital phenotyping, new statistical techniques. We are better positioned now than ever before to uncover some of the nuance in the ways in which people are engaging online and how it might be impacting their mental health. And I do think that we are well positioned now to understand how we can maximize those potential benefits and minimize potential risks in online spaces. That may be through things like enhancing young people's digital literacy, encouraging digital citizenship, and, as I'll talk about in the next few slides, perhaps helping parents set limits and effectively parent their kids in the digital age. So there are lots of intersections between family life and young people's digital worlds. We won't have time to talk about these all today. What I'm going to be talking about is more this idea of technology engagement as a target. So how are parents setting rules, talking to their kids about their technology engagement? And I will say this is a thing that pediatricians, doctors, psychologists like myself, it comes up. So a majority of parents are concerned about screen time in their kids. They see the headlines. And a lot of them have reached out to doctors for advice about this. So 61% of folks in this survey reported that they had ever gotten parenting advice or information about screen time from their doctor or other mental health professionals. So there's an opportunity here. You all, armed with evidence-based interventions, could help point parents towards some evidence-based resources. And it is causing difficulties in their households. Media use is a huge spark for conflict in families. About a third of parents and teens say that they argue about device use daily. I will underscore, though, that this isn't more than they fight about any of the other stuff that parents and teens tend to fight about and have been fighting about for millennia, including things like bedtime and chores. So it is a spark for conflict, but it is not the most frequent spark for conflict. Okay, so what can you all as practitioners be telling parents? The first thing that I like to remind practitioners is that the principles we already know about what effective offline parenting is also apply to media parenting too. So some parents, I think, feel inefficacious to parent their kid around their device use because it's this new thing that didn't exist when they were growing up. They don't have a model of how their parents parented them because they didn't have a smartphone. That's okay, because many of the tools that these parents already have been using throughout this child's life, like setting consistent rules and having a discipline system that is decided upon ahead of time, applied consistently and fairly and in a developmentally appropriate way, those things still work when the target of the rules is screen time. I also like to remind parents that authoritative parenting tends to have the strongest evidence base for enhancing positive youth development. So a parenting style that balances limit setting and monitoring with responsiveness and connection and warmth tends to be the magic combination. Parents can encourage, practitioners can gather information about families and their tech ecology. This is a really nice paper I like to point folks to by Lim and Solano in 2024, where they created a little list of questions for practitioners to ask parents and kids about how they're engaging online. And it moves far beyond how much time do you spend on screens. Thinking about how parents and caregivers talk to the kids about social media. What do they know? What's their level of knowledge of what kids are getting up to? And a neat thing about this is that they've prepared these questions both in English and in Spanish. So they are available for folks to use with a wide diversity of families. So in our last 5 minutes, I'll share a few of the media parenting practices that we do have some evidence work to different degrees. So the first one I want to highlight is restrictive mediation. So this would be the extent to which parents are setting rules on how much, when, with whom young people are engaging online. Most parents are doing this. So 86% of parents, for instance, limit the time of day or length of time that a child can use screens. We do know that the use of restricted mediation tends to shift over the course of development. So as teens get older, parents are doing this less. And I do like to remind parents that this doesn't have to be a tech-heavy strategy. Some parents feel like they need to be using apps to set the limits and where it'll turn off automatically. That's all fine and good, but some parents don't feel like they have those digital skills or the literacy to do these high-tech solutions. That's fine. Old-fashioned restrictions like saying no phones at the dinner table or no phones in your bedroom after lights out, you have to charge them in the living room. That's also a great way to set these types of limits. Monitoring is about knowing how much, when, with whom, and what youth are doing online. Again, this can be done face-to-face or using tools. So there are content monitoring apps that will kind of raise red flags if your kid is engaging using words around, say, suicide or bullying, driven by AI. Those are okay. I will say there's a great risk for false alarms there, and some youth perceive those types of apps as extremely invasive. What we do know is that covert monitoring, so snooping on your kid without them knowing that you're going to do that, tends to be bad for the parent-child relationship and ultimately results in more secrecy and kids going underground. Research tends to find that monitoring that is done out in the open, so having a really open conversation about whether you're going to be checking your child's phone, for instance, and saying, one criteria for you getting your own smartphone is that you're going to have some limits set on it, and I'm going to need to be able to check it. I'm going to need to have your passwords. That kind of open, collaborative conversation tends to be received better by teens and have less kind of reactive pushback. Discursive mediation is mediation that's more active. So these are conversations that parents are having with their kids that usually increase parent knowledge about the ways in which their kids are engaging online. So this is a great way to know more. And it actually can be a really nice way for parents and kids to feel connected and actually have media use maybe be a place where their relationship can grow and evolve and strengthen. So we see that discursive mediation is quite consistently linked to benefits for the child and their well-being and mental health, but also for the family and their relationship. Participatory mediation, and sometimes called co-use, is the extent to which young people are using technology with their parents. So this is the most common for TV watching. Most of us do this with our kids at some point, watch TV, but it also happens for gaming. Video gaming, as in this picture here. It happens a lot less on personal devices, but when it does happen, say a young person showing their mom what they're watching on TikTok and how it made them laugh, it does seem to see positive outcomes, especially for the parent-child relationship. And then finally, we have modeling. So young people see what their parents are doing. They are aware how much time their parents are spending on screens. They notice if their parent is distracted by their device and not paying attention to their teen. And we do see that parent screen time does tend to correlate with youth screen time. So parents who are using more screens, their kids do too. And there is some evidence from the ABCD study, NIH's ABCD study, that more parent screen time is associated with more problematic use in kids. So we do want to be attending to whether or not parents are serving as good models for their kids, good examples, and perhaps help parents shift their own media patterns to help their kids grow too. Okay, and then finally, a thing that practitioners can do is they can point families to trustworthy evidence-based resources. As with many domains of life on the internet, there's a lot of inaccurate misinformation around parenting and around technology. And so I think one of our roles as practitioners can be helping parents find tools that are evidence-based and that will actually work. I've put some of these here. So the American Academy of Pediatrics has a really lovely family media use plan. They also have a Center for Excellence, Social Media and Mental Health that has excellent resources. Common Sense Media is a good source. TechnoSapiens is a parent-facing newsletter that has weekly kind of insights gleaned from the research on parenting and technology use, and these are all really good places. So I'll go ahead and stop there, and I'm happy to take questions.
Well, thank you, Dr. Jensen. This is a fantastic presentation, and thank you so much for all the recommendations that you provided for ways that providers can support families. We'll dive right into questions. one of the questions was, are there implications and recommendations you may have for school settings?
Yeah, sure. This is a great question and one that's on everyone's mind. So North Carolina has just implemented statewide school cell phone bans. I'm sure many of y'all states are doing the same. Um, so schools is actually a place where we don't have a ton of research, but I do think this is a place where the connections are more obvious. So when a kid is on their device in the classroom, it's going to be distracting from reading from reading, but also from attending to instruction. And so I do think that school cell phone bans or softer kind of limits of not having phones out during instructional time is informed by this research, but not to as great as an extent as kind of non-school based stuff. We don't know yet how those school bans are going to go. There's been a few early studies, especially out of Europe and Australia, where school bans went into effect earlier that suggest that teachers are mostly liking them and are perceiving some benefits. Some kids are annoyed by them. Parents don't always love them, but we don't have great evidence yet on the outcomes we really care about, like learning. So like, is learning going to be reshaped by school phone bans? We'll have to see. I'm hopeful that it will be helpful. I doubt it's going to be a magic bullet school phone bans for, say, teen mental health problems. I think they're often pitched as like, this is going to solve all our problems. I think the current adolescent mental health crisis is much more complicated than that, and will probably not have so simple a solution, unfortunately.
Okay, thank you. You talked about this and provided some ideas, but I wanted to see if you had any other things to add about conversation starters and ways that providers can discuss, or providers or parents can discuss screen time with you.
Yes, and this is maybe like, if I have one soapbox I stand on, it's talk to your kids about how they're engaging online. We don't need fancy tools. We don't need surreptitious monitoring to help protect our kids in online spaces. Good old-fashioned around the dinner table or in the car on the way home from school conversations are really great. So I gave a list of some ideas there, especially for how practitioners can ask. I often encourage parents to ask open-ended questions like, what have you been doing online that's made you feel good? And like, just hear about some of their positive, uplifting experiences. Who are you hanging out with on there? Like, what are they like? What are you getting out of that? And then also leaving space for difficult experiences. So, have there been any things that have happened online that have made you feel bad about yourself, about the world? And I think that those types of open-ended questions don't assume the nature of those experiences, but indicate parental receptiveness to having those conversations. And I really do think that's important. You need to have a positive, warm, responsive relationship with your teen if they're going to come to you when they have a bad experience. So say they're discriminated against online. Say that they have a stranger message them an inappropriate picture, which happens. I think we would all agree that what we most want in that moment is for our kid to come to us so we can help keep them safe. And unfortunately, I think sometimes kids perceive their parents as being very restrictive and not open to hearing about the nature of experiences. And they're scared their parents are going to go scorched earth. And if they've had a negative online experience, they're going to take their phone, they're going to shut off the Wi-Fi, whatever. And they might be hesitant to share those experiences. So I do think indicating your openness to talking about it can really lay the groundwork for when something difficult does happen, they'll be open to talking about it.
Well, thank you. Is there evidence-based research showing the differences between in-person connection and online connections and the impact this has on kids and teens?
Really good question. We don't have, to my knowledge, and this is an evolving space, social connection is good. And so we know that social support is one of the most robust predictors of positive mental health. And we see that both in online and offline spaces. There have been fewer studies that have pitted those two like a horse race against each other and say, well, if you had to pick one, I tend to think that because there's a lot of things that are different about them. So the social network that you're getting supported by in a face-to-face interaction tends to be a tighter, closer social network, whereas you might be getting support from a broader, wider network online. I think they're both good and we don't want to discourage them. There's also risky social connections that can happen in adolescence, both online and offline. So some of my work has focused on things like contagion of substance use risk, talking to your peers about drugs and alcohol tends to be associated with risk for substance use, whether those peers are offline or online. And so I think that the social connections matter, and adolescents are really developmentally primed to care about their peers in adolescence. Evolutionarily, there's no point in development where people are more interested in what their peers are up to and caring about their approval. And it's because we're primed to affiliate in adolescence. This is the time when friends and romantic partners are really salient. And so whether those be online or offline, they really matter to teens.
Thank you. What are some signs that screen time is negatively affecting a child's mental well-being?
Yeah, good question. So I think that this gets at the idea that I really think is true, that for the most part, parents know their kid best. And so some of this is going to be an idiosyncratic answer. It's going to depend on your kid. So the big thing being if your kid is acting differently. So if your kid is really, withdrawn, say, when they're usually a gregarious, up and about socializing kid, we would want to be curious about that. And I will say we can't know without asking whether that's due to something that happened online. It might be, but it also might be that they had a negative experience at school or with a parent. And so I do think this really underscores the importance of talking to your kid and kind of asking, hey, what's up? I've noticed that you feel down lately. And so it's going to be really hard to know for sure what the cause of that is. But really, at the end of the day, you care that they're withdrawn, and finding out the cause is going to help you, and talking about it will be the way to do that. So departures from normal affect, normal behavior is important. And I would say, yeah, just open up those lines of communication to try and figure it out, and be willing to kind of get a professional involved if you need it for parents. I think often they'll notice the first signs, and then they come see us as a therapist, and we'll say, okay, let's figure out what's going on here. I will say very rarely is screen time the sole cause for what is going on for a kid. It's sometimes a contributor to a broader pattern, say, of anhedonia, where a kid is really just like checked out, doesn't want to go to school, having a hard time. They're spending a lot of time on screens, which is reinforcing that checked outness. But changing the screen time is usually not the only lever that needs to be pulled to get that kid back on track.
Okay, thank you. We'll try to do one more. Is there data on how much time is safe, and how much time would impact a child's mental health?
Yeah, so that literature, and I think this gets at the idea that it's really not about time. So if you spend 5 hours on TikTok, that's really qualitatively different than spending 5 hours on cooking apps and FaceTime. And so like the mix of how people are spending their time matters. I really am usually hesitant to give a hard, if your kid is using more than this number of hours a day, we should be worried. That said, some kids are on a lot, like all day, to the extent that they're not doing anything else. We need to be doing other things too. So I don't think there's a hard and fast number. It's more about what they're doing on there, and is it getting in the way of other things that would be enriching, like, say, sports, which have mental and physical health benefits, face-to-face social relationships, family, dinner, things that we know impart benefits.
Yeah, that kind of addresses another question, which was looking at other missed opportunities that a kid might have if they're doing other social activities.
Yes, and that is a big thing. So if your kid is on their screen a lot, but is still doing all the other stuff that you know is good for them and they love, I'm less worried than if they're spending a lot of time on their screen and they're not doing those things anymore. I think that does matter. And again, this will be a place where a parent is the best position to know what that right mix is for their kid.
Okay. And then maybe we'll try one more. Is there an age at which kids might be able to reasonably get a smartphone?
This is like maybe the most common question I get. It's like, when can I let my kid get a smartphone? I unfortunately don't have a one-shot answer for parents on that. It's going to be kid specific. There are lots of considerations that go into when parents decide to get their kid a smartphone. Divorced families, for instance, who are co-parenting often find that the kid having a phone is really helpful for them, making sure that they get picked up and that they coordinate things and they have a line of communication to their kid. And that's a really family-specific consideration that does not apply to all families. I will say what I encourage all families to consider is before they get a smartphone, they should think about easing in to not jumping both feet in at the same time to everything that the internet has to offer. So I encourage families before they get a smartphone to work through that family media use plan and think about what limits, what policies, what rules are we going to have in our household about this. Maybe thinking about putting on some parental controls. So if your kid is younger, not giving them the entirety of the internet, having a lot of these conversations early, monitoring more when they're younger and they're starting out. So I often describe this as like a training wheels approach. We most kids don't just start riding a bike and are great at it the first time. They need some practice, they need some help, they need some training wheels, they need their parent holding onto their back and helping them. We should be supporting kids in that same way as they start to enter into online environments. And so it could be that a younger, a 10-year-old is ready for that with appropriate supports for a smartphone, whereas another kid maybe later would be more appropriate. And the family may be more willing to provide those supports in a different way.
Right. Well, thank you. Well, this will conclude the Q&A. Thank you again, Dr. Jensen, for an excellent talk and sharing your knowledge with providers in Iowa. We appreciate you joining us today.
Thank you very much.
Thank you. So we will now transition to our next presenter. I'm pleased to welcome Dr. Chantal Rozmus. Dr. Rozmus is a staff psychiatrist in adult and child and adolescent psychiatry with the Abbey Center for Community Mental Health. She will be presenting on harm reduction approaches to adolescent substance use. Welcome, Dr. Rozmus.
Hey, how's it going, guys?
Great.
Good to see your face after emailing back and forth for a while.
I know. It's
Yeah.
wonderful to meet you
Yeah.
virtually.
All right, let me get my presenter mode pulled up and then I can share. Okay, so can you guys see my
Yes.
Perfect. Okay. I'm gonna just pull this up really quick. So I've got multiple substances I'm going to talk about. If you guys want to weigh in on what you want to make sure I talk about, I'm going to try my best to get through everything. But if anybody has any strong opinions, I'm happy to tailor this for folks that are watching. So cannabis, nicotine and tobacco, alcohol, what I'm calling uppers as kind of a group of substances, downers, and then psychedelics. Spoiler being the psychedelics data is not great at all. So if you're hoping for some fun data, that one's not the one to pick. I'll just give a couple seconds for this, and I can go ahead and look at my other two things first. So my name is Dr. Rozmus. You guys can refer to me as Chantal. That's what I tell my patients. I'm a staff psychiatrist at the Abbey Community Mental Health Center over in Iowa City. Today, I'm going to talk to you a little bit about how I approach conversations with adolescents regarding substance use. Just wanted to include a land acknowledgement that I'll let you guys read real fast. And I don't have any financial disclosures. I've been part of the executive board for the Iowa Harm Reduction Coalition since 2021. Some background information that kind of impacts sort of the way that I approach things is that I was born and raised in Iowa, did all my education in Iowa. Identify as queer and bisexual, and I approach things with an abolitionist mindset. So we're going to talk about different substances today, sort of in general. What does that look like in Iowa, and discuss harm reduction approaches that can be employed with these different substances. It looks like we for sure want to hit nicotine and tobacco, alcohol, and cannabis. Cool. So who are we talking about today? So adolescents, 12 to 17-year-olds. What I think is really important to know, and I think what comes up often when I'm talking to folks, is that this is kind of a developmentally appropriate time for people to be taking risks. this is when teenagers are pushing the boundaries. And so I think a lot of people, like, they don't want their kids using drugs and alcohol, which is super reasonable. And also developmentally, like, it kind of makes sense. Over the past 20 years, substance use has decreased pretty significantly. Kind of another trend that we've seen though recently is that vaping has resulted in an increase to nicotine and cannabis use, which I don't think is probably a surprise to people here. And then there's also inequities that exist. So any of the data that I talk about, you can probably increase the risk associated with it if anybody falls into a racial, socioeconomic, or like sexual orientation minority. So these are the drugs we're going to talk about today. We can go ahead and get started. So what's the harm that we're talking about? So we're going to try to reduce harm or mitigate risk if we go with the SAMHSA's new recommendations. Earlier onset of substance use is associated with substance use disorders later in life. It increases risk of motor vehicle accidents, non-accidental injury, STIs, because while someone's intoxicated, high-risk behaviors are more likely. Substance use can be a form of self-medication for undiagnosed or untreated mental health concerns. So the two often go hand in hand, and it's something that I spend a lot of time on in my own practice. Jumping into nicotine and tobacco, the data that I'm going to present comes from two different main resources. So there is this, SAMHSA released a 2024 sort of like broad view of substance use in the country. The individualized state data, though, is from 2022 to 2023. That hasn't been parsed out of the 2024 data that's been released. So in comparing I'm comparing two different years to each other. But within the data that was released for the 2024 stuff, they do give sort of a sense of, like, at the national level, is the use, or is this substance being used more or less compared to the previous years of data. So nicotine itself is considered to be a stimulant. That's how I would group it when I'm talking about substances. Generally speaking, tobacco use is decreasing, and it's primarily because people are using nicotine products, specifically in the vaping, with vaping as sort of their method of use. So within Iowa, the percentage of adolescents from 2022 to 2023 that were vaping was around 8%. So it was higher than when we look at the national average, which I thought was interesting, and I've been thinking about it a little bit. I don't know what to attribute that to. I was surprised by sort of the amount of difference between the two. I'd be interested if anyone's got any ideas during question answer. And then, it's pretty unsurprising, but vaping nicotine for 12 to 17-year-olds, that tends to be the primary form of what they're using for nicotine and tobacco. And so this is just a graph that sort of highlights this. And it is it's kind of dramatically different if you look between the age groups, that, like, vaping is such a large portion of 12 to 17-year-olds. I think you could argue that, I know the argument exists about companies sort of targeting this group with advertising or the flavors that they use. To me, it would, I wonder if it's just like accessibility. I think vaping is just like the cool thing, but I also think that there is some, when I talk to teenagers, like, if I ask them if they're smoking cigarettes, right, they kind of like, oh no, I would never do that. And so to them, vaping nicotine is pretty different than smoking cigarettes. And this would have been data from 2022 to 2023. So Iowa in that period of time, cigarette use in the past month was 1.54% compared to the US average at that time. It was 1.28. So also a little bit higher than the national average. And this looks at nicotine vaping. And so this is where that 8.03% compared to the 6.82% comes from. And the distribution of sort of the different colors within this map is interesting because you'll see some patterns with other substances, but this one is kind of, in my opinion, the most random in that, like, it's kind of, there's some stuff in the West, but there's also some stuff in the South, and it doesn't seem to follow like any particular pattern. Whereas some of the other substances, if I get to them, they do. So what do we do? What are some harm reduction approaches to nicotine and tobacco use? I think I have treat the underlying diagnosis on every single slide. So you're going to get sick of hearing that, but I think it's worth noting. I think you hear about people using nicotine or tobacco to sort of relax. It helps them calm down, even though it is a stimulant. You can do tolerance breaks, or T breaks, we'll sometimes call them. And so that just meaning like we are gonna take a break from using so that we're using less, like you need less to get to that same feeling that you're going for. And then there's nicotine replacement treatment. And so the data for NRT is not super great for adolescents. The most recent data that I've looked at, there was nothing that supported using bupropion or Wellbutrin or like NRT, nicotine replacement treatment, so patches, gum, lozenges. That being said, like off-label use can be considered, and both the American Academy of Family Physicians and American Academy of Pediatricians support that off-label use for folks with moderate to severe dependence. And within Iowa, you have to be 13 to consent for Quitline Iowa, which is a resource that can help connect people to free NRT, which I think can be really helpful and maybe ease the minds of some kids or teenagers with, their parents, if their parents don't know they're vaping. Is that something that they can get treatment for outside of insurance? Anecdotally, I would say nicotine is the substance that I hear most about adolescents wanting to quit. So I've used NRT on an outpatient basis, specifically lozenges and patches. When I was still training at the university, we often used patches on our inpatient psychiatry unit. I don't know if that's changed, but we did that pretty often. And when I explain that to people, right, because I think we will get some pushback from parents, like, I don't want them to use nicotine replacement. And the challenge that I give them is nicotine is hard to quit. Like if you talk to anyone who's tried to quit nicotine, it's not once, it's not twice, it's multiple times, and it's really difficult to quit. It's that quick onset of the head change and quick off, right? So, and that quickness really like makes people use more frequently because they end up like chasing that high, if you will. And I think it's, to expect a 12 to 17-year-old to handle that as well as an adult who has developed hopefully coping skills to deal with things that are uncomfortable, I think can be kind of hard. And so I do think that NRT can be helpful for kids because it's hard for me to expect a 14-year-old to handle quitting nicotine better than an adult. There is available evidence that says that vaping nicotine is less harmful than smoking from like a carcinogenic standpoint. But then you also have to figure in, often people then will increase the nicotine consumption with vapes. And that's kind of what I see as the primary, like, I hear that over and over again, right? Like they're not smoking cigarettes, but they're using so much nicotine that a 21 milligram patch is not going to cut it. And so here is just a quick comparison of different nicotine products. Kind of like legal update stuff. So in 2024, Governor Reynolds did attempt to limit what vape products could be sold in Iowa based on FDA authorization. And so that would have banned a majority of vape products that were available. The pushback from retail places on this was that if you ban those, you're basically taking away all of the vapes that we can sell, and you're going to limit our ability to make any money, and this will probably lead to us closing. With that, I think the only one from like this page, I believe, was like the Views pod was eligible per that FDA thing. But in 2025, a federal judge did block this ban, stating that it violated the U.S. Constitution's supremacy clause because it would have allowed the state to enforce federal tobacco regulations. And so that power has previously belonged to the federal government, so this did not go into play. One of the more popular vape products is, if you've heard of Geek bars, you might hear that like those are unavailable right now. And I looked a little bit further into that because I assumed, I don't know, I assumed it was something related to the 2024 law that ended up getting blocked, but it's actually because of the tariffs that have gone into effect by the current federal administration. So it's too expensive to get Geek bars to sell anymore. You might hear people talking about that because I do think it was a pretty popular product. All right, cannabis, moving on. So cannabis can be used in a lot of different ways. So you can smoke like the flower or bud of the actual plant. You can vape it. You can eat it or drink it. You can use it topically, take it as pills. Use concentrate, so someone might call it like dabs, wax, or shatter, and it can also be used sublingually. So there's a lot of different ways that we can use this substance in particular. So what does that look like sort of for adolescents, especially in Iowa? Vaping cannabis has more than doubled from 2013 to 2020. And I think like that to me is not a huge shock. I think it's a little bit easier to cover up your use. And so when I talk about this drug stuff too, I try to put myself in the place of a teenager, right? Like if I'm using substances in my family, I don't want my family to know. How can I get away with it? And I think the vaping, not only is it more readily available, I think it can also be a little bit sneakier. Within Iowa, the past month use in 2023 was 5.17%, and that's cannabis, sort of any type of use, which included vaping. Surprisingly, the 2024 data still shows that the preferred route of use for 12 to 17-year-olds in the US is smoking. The vaping rate was pretty close behind that at 72%, but I was still kind of surprised at the 75%. I kind of attribute that to sort of like historically, that's the way that stuff was used. Comparing last month use of Iowa to the US average in 2023 was 6.22%. So we were a little bit lower here. I think the big thing to talk about with cannabis use that I focus a lot of my time on when it comes to harm reduction is explaining that the products now are very different from the products from before. So the products that are available right now are significantly more concentrated. So in the 1990s, THC content of the cannabis plant was 4%. In 2019, it was increased to 14%. And so when you're talking about things like wax, hash oil, or shatter, the THC levels can be like super high, like 69% of the product. There's also considering sort of edibles, and I would say edibles tend to have a higher THC concentration as well. So I think that that is important when we talk about the implications for mental health use. And so here's just a graph that kind of compares our use. And so this is kind of the patterns like that I was talking about, like that sort of like Midwest, northern area, the Dakotas, Nebraska, and Iowa, kind of sticks out to me, as well as, I mean, Texas is a large area. And then I wanted to kind of superimpose sort of what that looks like location wise for us, because I think that surrounding states legalization practices does influence us. So the little like crop sign for me, my what do I want to call it? My key is that hemp products are legal, so it tends to be specifically low THC CBD products. So that's the case for Iowa and Wisconsin. In Minnesota, Illinois, and Missouri, they have legalized adult and medicinal use. In Nebraska and South Dakota, it is limited to medical use. So, a couple of things that stick out to me from this, Iowa, like I said, the use in 2022 to 23 within the last month was a little over 5%. If you compare that to alcohol use in Iowa, the alcohol use was at 6.6%. So people are using alcohol still more frequently than cannabis within the states that were legalized. So kind of the trend overall is that alcohol was used more frequently than cannabis. But if you look at Illinois, the use of cannabis goes up to 7.56%. I'm sure it has something to do with the legalization. But I also think, the number is not zero for any of these places. And compared to a lot of the other illicit substances, so things that are against the law, and I just say that to highlight the difference between like nicotine, tobacco, and alcohol and some of these other substances. It's significantly higher than those other substances that are considered to be federally illegal. So cannabis that's legal in Iowa, really. This is a thing that exists. So there are infused drinks that are available, gummies and candies. The reason that this exists is that the Farm Bill that was passed in 2018, hemp was defined as cannabis that contains less than 0.3% or less of THC by dry weight. And that dry weight is an important part of this. What can be done is that the THC can be sort of concentrated down, but it still comes from a hemp plant. And so that is the big difference. Within Iowa, so as of July 1st of last year, the laws have started to change regarding this. So Iowans 21 and older can legally purchase consumable hemp products, but they are limited to 4 milligrams per serving or 10 milligrams per serving per container total. So like, for example, if somebody got like a container of gummies, it would only contain up to 10 milligrams of THC. This also prohibits synthetic THC from being used in products, and there has to be a warning label on the product similar to labels on alcohol. The per serving thing is based on the federal serving size is 12 ounces. So within a 12-ounce can of an infused drink, you can only have 4 milligrams of THC. I don't often hear about adolescents using infused drinks. I hear about edibles and particular gummies probably most commonly when I talk to teens about this. So harm reduction approaches for cannabis. We should treat the underlying diagnosis. Again, tolerance break is something that I talk to anybody who uses cannabis about. So coming down, like taking 4 or 5 days off can really change the amount that you're using overall. And I think education is one of the places that I spend a lot of time when I'm talking about cannabis with adolescents. And so I really spend a lot of time talking about the differences in products. So as far as comparing like smoking flower to edibles, they're broken down in different ways. So if somebody smokes cannabis, the THC is going to affect you at a different rate, and there's a reason for that. The metabolization of when you smoke something, you get this balance of delta 9 THC and then 11 hydroxy THC. When somebody uses an oral consumable, the way it's metabolized, you end up with a significantly higher ratio of that 11 hydroxy THC, and that's more potent and it lasts longer. And so it's a different thing, that it's a different way of consuming something. And I think it's just important to inform people like, hey, if you've smoked before and you've not done edibles, it's going to be different. It's going to be a different experience, so that maybe they're more apt to use less. And that's kind of the big rule with harm reduction. You can always do more, you can't do less. Edibles can take between 45 and 60 minutes to start working, but it can also take up to 2 hours. So telling people, hey, if you're going to dose with something, wait, don't immediately take something again. And this is where it gets into the stories of like someone having a candy bar that's got cannabis in it, and I take one bite of the candy bar and 30 minutes later I don't feel anything, so I do 2-3 more, and that doesn't end well. That ends up, that's where we see kids in the ER, because the THC content of edibles, like I said earlier, is a lot higher, and so we're seeing higher levels of THC. And that can also, with the edibles, like I said, the 11 hydroxy THC, it can cause that more of that heart racing sensation that I think people will come into the ER with, saying, I'm really anxious, my heart's pounding, I can't calm down. And it makes sense because that's how it is metabolized with those products. I talk to people about not using and driving. If you use one of the products that's legal in Iowa, it will still show up as positive on a drug test. It's not fake weed. It just comes from a hemp product. The THC is still THC. And if someone's got a history of bipolar disorder, that's kind of my one group of people that I really stress, like, hey, weed is really, really, really bad for your brain in particular if you compare yourself to somebody else. I think the number of cases of mania that I see that seem to be precipitated by cannabis use is pretty high. I compare it to them as like, if I know I have a risk of alcohol use in my family, I'm probably going to be really careful about my own alcohol use. Just so, if someone has a risk of bipolar in their family, they might not use cannabis, in particular high THC concentration products. What tends to be kind of a surprise to people is that harm reduction wise, if because of the THC concentration, I actually typically recommend people switch from a vape or a concentrated product to flower. I think with smoking flower, there's a lower THC concentration, but also I think people can sort of gauge how much they're using a lot easier, which is kind of mimics sort of the nicotine, since like what we see in nicotine, right? Like they might be not smoking the combustible tobacco, that's cool, but you're probably using more nicotine because it's a vape and it's accessible and it's really easy to just hit it repeatedly. Okay. Wanted to just click okay, cool. So alcohol use, we'll get to now, and then I have hit all the important ones. So the numbers for alcohol use, the US to Iowa comparison, I was a little surprised by. I kind of thought that Iowa was going to be a little bit higher. but it wasn't. So in 2023, it was 6.62% compared to the US average, which was 6.88. Binge alcohol use, so drinking a lot of alcohol in a short amount of time, for Iowans in 2023 was 3.35%. And in 2022 it was 3.63. So there has been a decrease in binge drinking for 12 to 17-year-olds. If you look at the national data, 2024 compared to 2023, there is no significant change in alcohol use between the two. So it seems to be sort of holding steady. Anecdotally, I don't hear about alcohol use nearly as much as I hear about cannabis use, but statistically, alcohol use is still higher. So just another one of these maps to compare the two, sort of Iowa to other places around us. I kind of thought Iowa was going to look more like Wisconsin, if I'm being honest. That's what I expected. So I was a little bit surprised by that. And I think like growing up in Iowa, sort of like Iowa culture, I just always remember everybody's like in a small town, like the garage doors were always open. Everyone always has the garage fridge. And so I don't know who started doing this, but it just was very, very common where I grew up in Williamsburg that everyone kept their alcohol in the outside garage fridge. So I think accessibility is pretty easy. I don't know if families are still doing that, but I remember that vividly from when I was younger. So what do we do about alcohol? We're going to treat the underlying diagnosis. Hydrate, hydrate, hydrate. I stress this a lot. So it always sounds cheesy, but I tell people do the thing where you alternate drinks. If you have a beer, drink a glass of water between, your next beer. The other stuff that I will talk to folks about, and I would say this is more frequent with adults than adolescents, but I think it's a good example of harm reduction in general. I'll challenge people to drink beverages that have a lower alcohol content. So rather than drinking something with a 9% alcohol content, can you pick something that has 6%? Or if you buy a 6-pack of beer, can you take 2 of them out, and when you're done with those 2, you can't go get the rest of them? Or instead of buying a 24-pack, can you buy a 6-pack? And I think those like built-in things, it's a lot easier to do some of those than it is to quit something cold turkey. With alcohol, like cessation, we do have to be concerned about dependence because you can't have seizures and withdrawal. And then not drinking and driving. So having the conversation with teens like, hey, like, your mom and dad might not want you to drink. My guess is that they know you're drinking already. So I think they would much rather that if you did drink, you called and got a ride home. And I've been part of these conversations before that have gone really well, where I asked the teenager, hey, can we talk about this with your parent? The parent comes in and I'll say, hey, like, are you surprised to hear that so-and-so is drinking? And usually the parent says, well, no, of course I'm not surprised. And so then we just talk about a safety plan, right? Like if you're going to be drinking, would you much rather they called you instead of driving? The answer is always yes. And is this where questions come into play?
Yes.
Cool.
We can dive into questions, or if you wanted to, if there's other content you wanted to cover, we could certainly do that.
I would say the only like couple of like things really quick. So as far as like uppers go, which I included methamphetamine, prescription stimulants, cocaine, crack cocaine. The 2 things that stick out are that prescription stimulants are the most likely to be abused or misused, as compared to meth or coke. But what was interesting was that the only substance that had a significant difference from the 2024 data to 2023 was actually cocaine. So there was a significant increase within 12 to 17-year-olds in cocaine use in particular. It was not for methamphetamine or prescription stimulants. And I just thought that this was like a lovely depiction of that. We can talk about kratom at some other time because I'll get into this. Kratom is a kind of, I guess, briefly. Kratom is kind of these. They're sold in like gas stations and head shops. What's important to know about kratom is that at low concentrations, it acts like a stimulant. So it's a pretty interesting substance, like chemically, because then at higher concentrations, it works like an opioid. So why is this a problem? The way that it's typically sold in gas stations is you see these little like shooters, right? Like 5-hour energy shot. And I think what that size communicates to me as a consumer is this is a shot and that's one serving. If you look on the back of them, though, it is often not just one serving. I've seen anywhere from 2 to 4 servings per container. So what ends up happening is people end up consuming a lot more than they think, and it can quickly lead to a tolerance that looks a lot like opiate use disorder. And the kratom half-life is a lot shorter, so it's a lot quicker and easier to fall into that use pattern than it is with other opioids. Well, I can answer questions now.
Yes, and we had a question. This was in the regarding nicotine. Do you see a lot of ZYN users? I don't know if that's Zen or.
And yeah, I haven't yet. I hear about it more with adults, but I haven't heard a lot about it with kids lately. I think it's something that like I need to continue to screen for, but it's almost always nicotine vapes.
Okay. And what are some conversation starters if to broach the conversation with teens about substance use?
Totally. So, kind of like, there's some clinical pearls that I think are important for these conversations. So the way that I approach this is, and I will say this in front of the teen and the parents, if they want to talk together, I'll say it to the teen, as I assume that everybody is using every single drug in a way that is scary and having all the unprotected sex. So I'm going to give you some advice, or I'm going to give you some recommendations just in case you're one of those people. So this is a scenario where I do think that the assuming can sort of like take the pressure off of teenagers. I'm more likely to hear like, yes, that is something that I do, if they don't think that I'm going to go back and tell their parents about it. And that is confidential information. But I think, you're a little bit more likely to say that you're doing something if you think other people are doing it. And so I that's kind of how I approach it in general, because you aren't going to know until the teenager tells you. And so you can't do anything about it if you don't know about it, right? And so you have to be able to maintain some rapport and establish some rapport, which is why I think the harm reduction approach, while there's not a lot of data that's going to back this, but I think getting data to back harm reduction approaches with teenagers is hard, because not everybody agrees that harm reduction should be employed with teenagers, right? Like, I think overall, like, yeah, I wish that none of them used any substances. I wish that they weren't using any weed. I wish they weren't doing alcohol, but they are. But I think like it's a sticky thing to sort of try to get data on. But I don't think that telling a 15-year-old abstinence is the only way to go is very effective.
Yeah, thank you. That was another question, is really how the harm reduction approaches differ from more traditional abstinence based models.
Yeah, and it's just I think if I jump to like, hey, alcohol is bad and drugs are really bad, they're just not going to tell me. Like, that's all that it'll come down to. So if you have somebody that's even thinking about changing a habit, if they feel like you're going to judge them, or that you think they're a bad person for using it, they're just not going to tell you. So I feel like the harm reduction approach can be helpful for that. It certainly is not every parent's cup of tea. And I've experienced sort of the pros and cons of it in appointments from that regard.
All right, thank you. Well, it looks like we are approaching the next session time, so we'll bring this Q&A to a close, I want to thank you again, Dr. Rozmus, for presenting on this topic and covering so much information in a short amount of time. We
Yeah,
appreciate.
not a problem, guys. Thanks for listening to me talk about all this stuff. So,
Yes, it was a very informative presentation. Well, thank you.
yep, thanks so much.
Thank you. So it's my pleasure to welcome our next presenter, Dr. Jennifer Kuhle. Dr. Kuhle is a clinical psychologist and clinical assistant professor at the University of Iowa Department of Psychiatry. Her presentation is entitled Environmental and Behavioral Supports for Children with ADHD. Well, so welcome, Dr. Kuhle.
Thank you so much. Appreciate it. Let me show myself here. Hey guys, good morning. There we go. You can
morning.
see me and see the slides, correct? We are good?
Yes.
Beautiful. All right. So, like Coffee said, my name is Dr. Kuhle. I'm a psychologist at the University of Iowa, and I work largely with children who engage in severe and challenging behaviors. And then before I came to the clinical side of things, I was a school psychologist for 8 years. So I've got to work in both the kind of medical model of support and the educational model of support as well, which sometimes, as you guys are probably aware, contradict themselves or clash. So we'll talk a little bit about that here. I will probably have too much material, so feel free to reach out afterwards if I can provide additional details or additional clarification on anything. But with that being said, to make the most of our time, I'm going to jump in again talking about environmental and behavioral supports with for individuals with ADHD. As you guys are well aware, ADHD is out there and present in many of the children that we serve. The actual range, of course, is large, from about 8.5% to 15.5%, with the most recent data showing about 11.5% of our children population in the U.S. diagnosed. Higher prevalence in boys than girls, about 2 times as often in boys than girls. Then with ADHD often comes a lot of comorbidity with behavioral concerns, whether it's ODD or conduct disorder, and then anxiety and depression. So you guys are probably familiar, right? A lot of the boys are the ones who, excuse me, have some of those behavioral challenges, while the females are the ones that experience a lot of those internalizing challenges in addition to the ADHD. So I am not here to talk about diagnosing ADHD, but just to kind of center us and get us thinking about the different symptom presentations. Of course, we have the inattentive type, hyperactive, and then, yes, the combined type. So when we think interactive, the kids who might be able to sit at their desks or sit at a table, but aren't paying attention to details, who are easily distracted or forgetful, kind of our daydreamers, if you think of it, can struggle with task initiation, etc. But when we think hyperactive, those are our kids who are run by a motor, difficulty remaining seated, can struggle to take turns or wait to engage in conversation, always blurting, and then the children who have both symptoms. So again, the focus of this is going to be on treatment. So just kind of wanted a really super rapid, quick overview, but let's talk treatments. So there are 3 really kind of arms of treatment, as many of you know: pharmacological, so stimulant meds, and then non-stimulants if those are not working for children, psychosocial interventions, and then the combo of pharmacological and psychosocial. So lots of research for effectiveness of pharmacological interventions, lots of research about the psychosocial, and then the combo of the two in many cases can be more effective than just meds alone. But for the point of today, again, I'm not an MD or I'm not a med provider. We're going to talk about just those psychosocial interventions, keeping in mind the ways that we could help support families from a primary care perspective, the things that we could do in your particular settings to help families that might have a child who is either newly diagnosed with ADHD or has had the diagnosis for quite some time. So when we think behavior parent training, that is really just training of the parents and helping them create a different sort of environment at home. We talk skills training, thinking of building individual skills, executive functioning skills, organization, time management, task initiation, and then school-based support. So I'm going to go into each of these in quite a bit more depth. But this is kind of the three arms, if you will, of psychosocial interventions. I want to be clear that there isn't there's still like play therapy that people may refer to. There's not empirical backing or basis for play therapy for addressing ADHD symptoms. So I just want to say that out the gate. The ones that are listed have empirical backing and support for their effectiveness for navigating the challenges that children may have with ADHD. So when we talk behavioral parenting training, or BPT, it's just like an area that's ripe with acronyms. So there's a number of really formalized approaches, a number of really manualized or standardized treatment plans or protocols. Most people are familiar with PCIT, and then there's PMT, parent management, triple P, it's all the Ps, right? Star parenting, and then STEP. There's a number of other programs as well, but these are some of the most commonly listed or heard of programs for the behavior parent training piece of things. However, there's often a wait list to get into any of these programs, or there can be limited providers in the community where, excuse me, where someone may be located. So there's ways that we can start down this path, or there's ways that we can implement some of these strategies within these programs that don't require somebody to fulfill the full program. So one, that might be enough. That might be sufficient to get the family on track. It might not be, but it's still a really great start while the family is waiting. So I'm going to talk about ways that we can use portions of these programs, and not specific to one program, but just the general idea. Really, overall, the point is that we're establishing a positive parenting approach here. We're trying to get parents to get comfortable having like really clear and consistent guidelines in the home, and really clear and consistent expectations, which includes follow through on those expectations, right? You can have a great set of rules, but it means nothing if you don't do anything with them. So making sure that we are appropriately responding to positive pro-social behaviors, and then also responding to those challenging behaviors that might be present. So trying to help parents really reshape kind of their environment. So primary care providers can utilize, like I said, some of these specific areas to coach parents on some basic behavioral strategies. One thing that we were trying to do, this is, we often see this with kids who have ADHD, whether or not there's an additional comorbid behavior diagnosis, but this coercive cycle that can happen where parents will make a request to do something, the child refuses, or maybe they don't hear it, or maybe they heard it and then it got lost, right? So the parent responds in kind of a hostile way, or maybe even withdraws. The kid doesn't do what is asked, and the cycle repeats. We're really trying to get out or reduce any chance of this cycle happening if it's not already happening. So that's why we move to these positive parenting practices. We're really focusing with this. We're trying to change what we highlight at home. So in the positive parenting, this is not gentle parenting. Let me be clear. That is just a separate social media vibe. That's not what we're talking about here. Positive parenting is about using positive strategies, meaning the use of reinforcements, rewards to build up desired or pro-social behaviors. There's 3 areas that are easy to provide coaching on to provide some support: prompting, the use of attention, and then reward systems. So when we think of prompting, we're trying to help support parents in getting comfortable providing expectations and providing clarity to their child about what is expected. Quick disclaimer, a lot of my examples are younger kids, because right now that a lot of my clientele are younger kids. This is not a younger kid specific. This is the gamut, right? This can be applied across the child lifespan, if you will. So, excuse me. If you are looking for older examples, I'll try to pepper those in as well, but I wanted to be clear because it might look like I'm heavy-handed a little bit on the younger side of things. So again, we're trying to change what we focus on. And with kids who have ADHD, oftentimes parental prompting can be maybe heavy-handed, not intentionally, but we start to focus on the things the child is not doing, or the things that we are not getting done, or the way that they didn't listen. And it can quickly spiral. So shifting the way that we prompt. So here's really, really clear expectations for prompting that I like to coach parents on. And this is a little checklist that you guys can use as well. But when we're providing prompts to our child, think of having them be short, direct, and you're within proximity of your child. It is not an ideal situation to yell across the house, an expectation. We want the child to be in the same room with you when giving those prompts. And when I say short and direct, I'm not being short and direct right now, right? Short and direct would be pick up your toys, put your coat on the hook, not giving a long preamble about it, not continuing to talk after you've given the directive. It's just a short, simple sentence that tells us exactly what is expected. Also, specificity is incredibly important with our ADHD individuals. What exactly is expected? Saying pick up your room is pretty vague. Saying pick the items off your bed is much more clear. Or, hey, get ready to go isn't super clear. Very specifically, put your shoes on and get your jacket. Those are 2 steps though. So in some cases, 2-step directions might be too many. So we might want to back it up and ensure that parents are just using single step directions, especially with younger kids or as we're starting to build this competency. And the other thing I'll coach parents, and it's I would encourage the same, is use statements, not questions. So if we want our child to do something, if there's something we're expecting them to participate in, tell them what it is, just straightforward. Please finish the dishes. I want you to make your bed. It's time to get ready for school. If we flip those into questions, will you help me make the dishes? Can you get ready for school? We open ourselves up to children telling us no, which is fine, right? We want kids to have the autonomy to say no, but there's some situations where we frankly don't. We want our child to complete a task. We want them to follow through with something. So if there's something that is not optional, use the statement. Just very straightforward, very direct. And direct doesn't mean rude or disrespectful or cold. Please finish the dishes. Hey, come make your bed, please. All of those ways are very kind and compassionate ways to say, come do the thing, right? If we're opening up for a question and our child says no, I always tell parents if they say no, that's appropriate and that's functional communication, we should honor it. So we can get ourselves into a little bit of a sticking spot. So trying to shift from questions to statements. And then always just remain calm when you're prompting and no begging or negotiating. So don't try to set up a scenario like, please, if you please do the dishes now, I will do this for you. Please, let's get this done. That really kind of negates any of the prompting and can start a negotiation, right? A back and forth with your child. So prompting and changing the way we prompt can be really, really beneficial. There's one extra piece to this prompting that comes from the parent management world. Excuse me, apologies. That I like to train parents on, and this is a beautiful thing, and this can be a relatively quick conversation within the primary care world, but the use of positive opposites. Rather than telling a child what not to do, we want to try and tell our child what to do. This is that direct and specific piece that I was just talking about. Rather than saying, stop running in the house or don't walk away from me, we're going to say, walk in the hallway or keep your hand on the cart. Flipping our vocab and flipping the way that we as parents provide these instructions can be wildly supportive. This is one of my favorite things to coach parents on. And most people, our brains break a little bit because that's not our typical way that we communicate. We usually use a lot of no, stops, or don'ts. Why do we switch? Why do we encourage the prompting to shift to these positive opposites of what we want our child to do? Tells them exactly what is expected. There is no ambiguity, especially for our kids with ADHD who may have very limited attention spans. They're not sitting still. They're moving to the next thing. We want them to know exactly what we expect from them. So walk in the hallway. Walk in the hallway. That is just repeated expectations very calmly. If we keep saying, stop running, stop running, stop running, all we're doing in those instances is repeating and emphasizing the behavior that we want to have stop, the behavior we don't want to see. So it doesn't really help us build any of those pro-social desirable behaviors when you use no, stop, or don't. It also We can get rid of the assumption then that the child isn't sure what to do when we tell them exactly what is expected. There's no lack of clarity. There's no do they know, don't they know. We're telling them exactly what is expected. And it helps us ensure that there's ample opportunities for praise. Hey, Sarah, I need you to walk in the hallway. We see her walking in the hallway. Love that, girl. Great job walking in the hallway. Hey, Sarah, stop running. Good job not running in the hallway. It can be weird. It can be a little funky coming out, and it's not a supportive statement. It's not that like rich praise that you can get when using the positive opposite. So this is a really, really beneficial way that parents can start to prompt in addition to some of those other tips that I threw out there. So positive opposites, a great way to build that prompting sequence. Here's just some very basic examples of positive opposites. I'll give you guys just a second here to look through this table. So when we look at all of these positive opposites on this table, we are really taking anything that we could say no, stop, or don't to on the left side and giving us an example of something that we could positively tell our child to do. Rather than cursing at your parents, use kind words. Rather than running in the store, potential positive opposite, stand next to me or use your walking feet. Rather than screaming inside, use a lower voice, use an inside voice, whatever it may be. Even if your child is 16, 17, right? Rather than screaming inside, don't scream. Lower your voice, please. Sometimes it can just be the tone in which we say it to kind of span the age range. But positive opposites and that prompting is one piece of this behavior parent training that can be really supportive. The next piece is attention. Parental attention is so incredibly powerful. Like, it is one of the best tools. It's free. It's so free. It doesn't cost anything, and it's portable. It can go with you in any environment. You're not lugging something around. Parental attention can work in school, in home, in the community, at a restaurant. It's one of the best tools. And if we can get parents to kind of understand the way that their attention may impact some of the behavior, we can have some really, really awesome changes and for the positive. However, it's important to recognize that attention is attention is attention, regardless of the intent of the caregiver. And many times I'll hear parents say, but I was yelling at him, right? Or I told him sternly and he still keeps doing it. Yeah, but when we yell at a child or we talk sternly to them, what are we doing? We're giving them lots of really good one-on-one attention. And if the only time they're getting that attention is when they're doing something that's challenging or not following your direction or not completing a task, they're learning, this is how I get their attention. I just do these things that aren't particularly great or sought after, and then mom or dad or grandma's going to key into me and they're going to engage with me. So attention, when we shift how we use our attention, we start to shift the behaviors and the frequency of the challenging and positive behaviors. It sounds very simple, right? At the most foundational level, we increase attention for behaviors we want to see, and we decrease attention for behaviors we don't want to see. There's lots of nuances here, and if parents attend a more formalized program, you'll dig into all of those. But as we start to shift where we provide our attention, we can start to see these really beautiful changes from challenging behaviors to more pro-social behaviors. Again, that challenging behavior could be something that is like not starting a task or keeping our room dirty, any of those things. It doesn't have to be just overt screaming, yelling, aggression, anything like that. Keep in mind, though, that attention comes in all forms. Attention isn't just talking. It can be comments, though. It can be back rubs. It can be smiles, laughing. All of those are forms of attention that we have to pay attention to because we may want to either increase them or pull them back if we're using them as a consequence to not so positive behaviors. I have the plant on there because there is a phrase that I'm stealing from another who knows what training person, mentor, I'm not sure, but the things that we water are the things that grow. And I have loved that now for the past couple months. The things that we put our time and energy into are the things that are going to increase. So if we have behaviors that we want to see more of in our child, again, whatever it could be, the whole span or gamut of behaviors, the things that we spend more attention on are the things that we're going to see more of. So if we start to see our child initiate tasks and we really lean into that, let them know that we see that and pay attention to that, we'll probably see more task initiation. We see them sitting down and doing homework right away, and we really lean into that, we'll see more of that. If we see a lot of squirrely behaviors and we jump in on that and always jump on and always have our thumb on that when we see it, we'll probably continue to see those behaviors. So shifting of attention is something that we can coach parents on, even if it's just briefly, to start kind of noticing what they are not doing. Within that, praise is beautiful form of attention that gets really underutilized sometimes. It is one of the easiest ways to build appropriate behaviors, and it's a great thing to model in a clinical setting, whether it's myself in psychology and psychiatry in your primary care setting. But you can model with parents how to praise the child for doing anything. Hey, great job. Hey, thanks for coming in real quickly. Hey, thanks for being patient. Appreciate you waiting. All sorts of ways that we can praise just behaviors we see in the clinical setting. Hey, appreciate the conversation today. Hey, love the back and forth. Really, that was awesome. Thanks for the details. All of that in our own settings, we're modeling how to use that praise component for parents to use that at home and build it. Couple of elements of praise. We talk about being immediate, enthusiastic, and genuine, right? Kids can smell BSer, how about that? A mile away. So they can notice when something is not genuine or accurate. Using touch for some kids, and then being very specific about what you're providing praise for. Eva, I just saw your hand pop up. Did you have a question? You're welcome to jump in right now.
I think that might have been by accident.
Oh, okay. Not a problem.
Yeah,
no problem. So here's some rapid, quick attention examples. So I'm not going to go into these too in depth, but just kind of emphasizing the stuff, and you can use these to emphasize with parents. Classic example, right? Frederick tells a gross fart joke at dinner every day. His dad shakes his head and goes, dude, gross, disgusting. What do you think Frederick's going to do every dinner? That boy is going to tell a fart joke every single day, and they'll probably get more grotesque because dad's responding to them. If that's met with no attention, after a couple of fart jokes, we're probably done with those. On the plus side, Dante calls for help from his parents rather than climbing on the counter. Dad comes into the kitchen, helps, gives him that attention, praises him for asking for help. What do you think will happen? Dante will learn to request help more frequently. Very basic, broad examples, but just to kind of emphasize those points. And then from the parent standpoint, I want to end here with reward systems, another really coachable thing we can help parents put in place, even in the primary setting. This is using positive rewards, positive reinforcement, praising for doing the quote unquote right thing, or the positive opposite. What I did there, brought it all back, right? We can praise and encourage those positive opposite behaviors. The goal of reward systems is to increase desired behaviors. As we continue to increase those desired behaviors, those less preferred behaviors typically decrease. It is best when there's both immediate and delayed rewards, but that can shift, and there's lots of nuance here. And so this could be like multi-hour seminar on reward systems. So I'm just giving quick and dirty, and some of you are likely very familiar with these already. Here's a whole variety of simplified charts or systems that you can use. It can be as simple as a punch card, a marble jar. It can be physical, where you actually create a bracelet and create beads and put beads on a string for somebody to earn, to actually use a marble jar. It can be just on paper and just this visual. But the visual part is particularly helpful, especially with our ADHD kids, having that piece to look at and to monitor our own behavior. So it's best. Also, having the visual usually keeps parents accountable or caregivers accountable. Here are more kind of intense or involved chart examples. I just wanted to show you there's a whole gamut. And then we can take this to even a more developmentally appropriate level and use point systems with kids who might be more advanced or who have no desire to use a star chart if it's too little or too young for them. So there's ways to build all of these reward systems. Couple of pieces though, when we're helping families build them and things to consider. Rewards do not need to equate to money. Resources are precious and finite. So this is not, many times parents will say, hey, well, dang, we've already spent $100 and it didn't motivate them. Many times though, like the thing itself isn't the motivation, it's the attention. It's getting to do something with somebody and the interaction. So building up privileges, activities, stuff that the family can do together, or the individual kid can do with a a parent or caregiver can be enough to build up motivation to engage in that reward system. But a couple of things I want to talk about briefly from reward systems. We want to make sure that we're starting really small to ensure success. Usually what happens is parents will have, or caregivers will have, a very lofty goal. I've had a family say, hey, if they do good for 3 months in school, we'll look at getting a cat. Dude, I don't know if I do good at 3 months in a row at work, right? Like that's very lofty. I'm not probably going to ever get that thing. So, and also a cat, quite a lofty reward. I don't know how you top getting a kitten. So help parents kind of navigate what would be reasonable behaviors that we're trying to build and what would be reasonable rewards that we're trying to earn as well. When we do this, I want to go back to that specificity piece. It is incredibly helpful for our children, ADHD and not, to have very clear expectations. So we want to say, hey, we're going to work on you getting off the tablet when we ask you to. We're going to work on you having your homework done by 6 p.m. Very clear criteria for what's going to earn the thing. What can happen is, hey, we're going to if you have a good day at school, what's a good day? Everybody's judge of good day is different. There's too much subjectivity with that. And then we don't even know what we're actually building or earning, if that makes sense. We're just kind of this vague idea of, I think I was good. But if we very clearly say, hey, you're going to get rewarded when you get off the tablet, successfully 3 times in a row, we're going to have a movie night. No, that is very, very clear criteria. And it's framed in the positive. It's not when you stop refusing to get off the tablet. No, when you get off the tablet when requested. So again, those ideas of framing things in the positive and those prompting. Also, another little quick aside, make sure once the reward is earned, we get it. Even if we've had a bunch of other challenges related to other behaviors, we still want to demonstrate that you're earning for the good things that you've built up for this specific behavior on the reward chart, which is why we emphasize specificity. So in summary, I need to move faster. And positive parenting, we're trying to focus on the good. We're trying to take away highlighting all of the challenges and negatives and the nagging that might occur, and really trying to shift our parental focus to the positives and really building up those particular pieces. So I want to talk now a little bit about skills training and ways that we can build in supports or help family identify supports that could be helpful for any kind of executive functioning skills. Think time management, think task initiation, task completion, prioritization, etc. Couple of reasons these are incredibly beneficial. One, we help just develop the skill, right? Also, it encourages independence and helps our child start to identify skills or strategies they can use independently. And then it reduces behavioral conflict. Mom is no longer nagging you to get the thing done. Dad is no longer telling you to do this. You have these systems, you being child, that you now can utilize. And so you can get ready for school on your own. There's no one harping you. And so the whole kind of relational change and family change can shift with this, make everybody just feel a little bit better. And a lot of this is based on visuals, especially with our kids with short attention spans or, excuse me, who might not be able to follow through a long list of things. Visuals, visuals, visuals. Emphasize the use of visuals. So many ways that visuals can be utilized. I'm only touching like a tiny little pinpoint of these visuals, but here's a flavor of things that can be used and ways they can be used. Very simple checklists or to-do lists. You're probably like, yeah, duh, Jen, that's like not super innovative. Yeah, you're right. It's not, it doesn't need to be. That's the best part. Sometimes using the simplest of strategies can be wildly beneficial. There's a whole host of ways we can do visual schedules. The flexibility of this intervention is beautiful. It can be wildly individualized. You can use pictures. A lot of these on the screen do look like they're for much younger children. So if you have an older child, you can take out the pictures. You can use text only. If you have a child at a lower developmental level, you can take out the text, use pictures only. Whole variety of ways to do checklists. You can see on the left side, the red and green schedule helps add another element of when something is done or not done, a really clear visual, moving it from one side to the other. There's the to do to all done in the middle, and then finally just a very basic checkbox checklist. This can be used for large portions of the day, specific activities, checklists, to-do lists, beautiful. Visual schedules. So this is more, a checklist is like, here's the things that need to get done. But a visual schedule will really help lay out the order in which something needs to get done. And typically one thing builds off of the other. Checklist might be like, do this math assignment and then feed the dogs, whatever it may be. But this visual schedule here, these really build sequentially. The two on the left, the morning schedule and arrival at school, are kind of just your generic get ready in the morning. These are the steps you need to take. These are the things that need to get done to get this portion of the day completed. However, on the right is a visual schedule specific to a routine. This can be particularly helpful when we're thinking about helping our children with ADHD build routines throughout their day, or help them get through parts of the day that they might forget about, or things that they might forget. Think hygiene routine. As our kids get older, hygiene, we want them to brush their teeth. We want them to comb their hair. We definitely want them to put deodorant on, right? I worked in a school, I know. And then we want to make sure that they've changed their clothes. And sometimes just saying, do your hygiene is way too much. That's too much of a task. So breaking hygiene tasks down into these individual steps can be really, really helpful. So visuals can be used again in a variety of ways, but sometimes just taking an individual routine and breaking those steps down is a great way to start here. However, need to caution, visual schedules only work as much as you use them. If you set it and forget it, you guys remember that infomercial? If you just create a schedule and then put it on the wall, nothing's going to happen with it. You need to make sure that initially parents are supporting using the schedule, reminding the child of the schedule, going back and referencing the schedule until that automaticity and that kind of check-in point is built in, which is also why figuring out where the schedule goes is really important. Making sure we're putting it in a high traffic area. If it's a hygiene routine, we obviously would want to keep it in the bathroom, probably not keep it on the fridge. So paying attention to those specific portions of schedules. And then visual timers, great for time management, great for understanding of time. On the left is an actual visual, like a physical one that you can purchase. So you will see the amount of time that has elapsed. If you are not great at even understanding clocks, right, or not knowing, or like only being able to read digital clocks, great. You have this much red, and when the red decreases, then you know your time is up. So it can be a great way to help kids. Also, great for routines. Hey, you have X amount of time to do your routine. It needs to be done before the time has elapsed. The countdown app on the right side is a free app anybody can get. It actually kind of works in reverse of the other visual timer, but a picture is created. So as the time elapses, you'll see a picture. There's like a drum, a duck. It is a younger kid audience for that app. But again, it's a visual timer, so a child can understand how much time is elapsing. Hey, we want to get this thing done before we see the ducky or before we see the drum. So a couple of areas that you can support and help families navigate or try some of these particular interventions. All right, school-based supports. I'm going to roll through this really quickly, but I want to, many of our kids that we see in the clinic setting have school challenges as well. So students with ADHD can receive accommodations through a 504 plan. 504 plan is accommodations only. It's a general education support. So they don't have to, and ADHD qualifies as one of the categories for those particular supports. However, many times parents will fight for an IEP, which is perfectly fine if additional supports are needed. But you do not need to have an IEP, which is special education, in order to access accommodations. When I say accommodations, I'm just talking about adjustments to the learning environment. We are not looking to change curriculum. We're just looking to adjust how our student is in the environment. And I'll talk through some, but I want to be very clear, like an IEP A child needs to demonstrate in Iowa that they have there's an adverse educational impact based on their disability, and having a disability alone does not immediately qualify you for an IEP. So a student can go in with a diagnosis of ADHD, frankly, anything, right? You can go into a school with a diagnosis, ADHD, autism, ODD, and unless there's an adverse educational impact, it's likely the team will say they do not qualify for an IEP. However, students can still qualify for a 504 where they will receive their accommodations. It feels a little nuanced, and also Iowa is the only state in the nation that is non-categorical, meaning that we just look at if an individual is eligible or not eligible, not necessarily the diagnosis itself or the category that the diagnosis falls under. If anybody wants to talk about this privately, I love this. It's where I came from, but it can be confusing and very overwhelming for parents, and there's not great support always or explanation for some of these nuanced pieces for accommodations. Here is a very brief and by no means exhaustive list of school accommodations that students with ADHD or anybody that would qualify for them or need them. Think about preferential seating, right? Do we want the student near the doorway? Do we need them far away from the hallway, close to another peer, close to the teacher's desks? How do they take tests? Does an individual need a less stimulating environment for test taking? One-on-one, small group, all sorts of things. Built-in breaks is a great accommodation, especially for our kids who struggle to remain seated for an extended period of time. Perhaps they get the material, they sit for 15 minutes, and then they can move about the classroom. Beautiful, great way to use breaks. Additional time to complete assignments, or maybe tasks are broken down for them. So rather than saying, hey, you have to do this whole worksheet, we give them a portion of the worksheet at a time. Skeleton notes, where you give notes that are partially completed or partially written in, and the child needs to fill in the rest of them. So they don't have to tune in maybe quite as hard, but we're still ensuring they receive all of the information. Any kind of fidgets or chair bands that help with movement. Recording of lectures or ensuring that students still have access, right? And that if they miss something, there's still a way that they can return to that. Checklists, same thing that I just showed you. Any of the things that we talked about in terms of kind of skill building, schools can absolutely implement or use them. Oftentimes it's about the advocacy of the parents or caregivers to try and make sure those supports are put into place, et cetera, et cetera, et cetera. You could go on and on and on. The important part about the school accommodation piece is making sure that it's individualized to your child's specific needs. And we don't just throw a whole host of accommodations at the kid, but actually what they need. Because if we put a whole host, there's also risk that not many of them are actually going to be provided or utilized. So I think I whipped through that a little late. So apologies. Some references. Let me know. There's my email if you guys ever want to reach out. I'm happy to talk about any of this more. I recognize this was just a really quick and dirty overview. So thank you guys for your time.
Well, thank you, Dr. Kuhle. This is
Absolutely.
this is an excellent presentation. I appreciate how much you were able to cover during this time. There are a couple questions, I think, following up on the IEP 504.
Yeah.
How can providers best help patients who are requesting an IEP or 504 and the school is maybe giving some pushback or that maybe they don't qualify?
So the school is the one that gets to make the decision for the IEP, unfortunately. I always encourage parents to get a parent advocate. Give me 2 seconds. I can tell you the advocates in the state. I believe, it's askresource.org is now the advocacy group for parents in the state. So if parents feel like they're not being heard or communicated with, I would encourage them to seek out an advocate and or have parents connect with the AEAs as well. Many parents, the AEA is the team member that will head up the area education agency. So our state, if everybody is familiar, we're broken down into 8 or 9 AEAs, and it's the AEAs that provide the special education evaluations within our state. It's done quite a bit differently in Iowa. So also connecting with their AEA team member and having a conversation with them can be a great way to gather some more information. It is a very tricky process to navigate. IEP is special education, 504 plan is general ed. So if you're looking for a 504 plan, that conversation usually happens with the school counselor or the school principal. So that can be a good starting point as well. Did I make that as clear as mud, possibly?
I thought that was good, and there were a couple
Okay.
questions, so
Yeah.
this was great to talk about this. Let's do this one more. How would you approach parents who have children with ADHD they're doing well with all of these interventions, but struggle to fully complete the task, such as cleaning their room, but leaves one piece of clothing on the floor? It seems the expectations can be very high and create a sense of needing perfectionism.
That's the tricky one, right? So it's some of that trying to set parental expectations. I will talk with parents a lot about shaping. We cannot expect perfection at the beginning of any of this, but this might be, hey, we work through things for a while and we're working on room cleaning for 6 months and we start to increase the expectation of that room cleaning. However, sometimes we get parents that have expectations that seem unreasonable, and then I kind of lean into some difficult conversations. I've had parents, for example, who get really hyper focused on cursing from their 15 or 16-year-olds, and I will sometimes just say real frankly, like that's developmentally appropriate. I'm not going to actually treat cursing, or if there's one pair of pants on the floor, that's not going to be probably my priority. Let's kind of talk about how we can prioritize some of these things. But if it's trying to get better, I'll start small, like shaping the behavior, meaning like increase my expectations. But if it seems more of a parental perfectionism thing, then it's just kind of a difficult clinical conversation that I'll have about what is reasonable developmental expectations.
Great. Well, thank you.
Mm-hmm.
Well, this was very helpful. You got a nice comment that this was excellent.
Oh, thank you.
And there is a question. Yes, we will be sharing a handout with the slides from the presentations today. It will take a couple days to get those uploaded, but I will share the link in the follow-up email.
Awesome.
Well, thank you again, Dr. Kuhle, and
Yeah.
I appreciate you taking the time to present today.
Absolutely. Thanks so much, guys. Enjoy the rest of your afternoon.
Thank you.
Yep. Bye-bye.
All right. Well, for our final session, we will hear about two resources to increase mental health access, Welltrack Connect and UI Consult line. To present on these resources, I would like to welcome Liz Gleason and Dr. Hanna Stevens. Liz Gleason is a social worker at the University of Iowa Scanlon Center for School Mental Health. Dr. Hanna Stevens is a child and adolescent psychiatrist and professor of psychiatry at the University of Iowa Department of Psychiatry. She's also the division director for child and adolescent psychiatry. So welcome to you both, and I'll turn it over to you, Liz.
Great. Thank you. And I'm going to try to share my screen successfully. Okay. Can you see that?
Yes.
Yeah, the
perfect
way maybe. Okay, awesome. So for the sake of time, I'm going to be probably talking a little fast. But I'm going to be talking about Welltrack Connect as a resource that you can offer to parents and families that you're working with. Also, I'll talk a little bit at the end about how you as mental health providers can create a profile on Welltrack. So the things that I'm going to kind of focus on is very high level overview, and this is kind of how I typically would discuss this resource with parents and families that you're working with. So I just want to say this up front before I forget, it's a free resource at this time, and the Scanlon Center doesn't get any kickbacks or anything like that from people using this resource. So please spread the word about Welltrack. It is an online platform that lists mental health providers in Iowa. And so I kind of describe it to parents and families as kind of like a search engine to kind of look up licensed therapists, counselors, medication providers, psychologists, and just different ways to access that care across Iowa. And it's really neat. There's a little screenshot over here on the side of what the front facing page looks like. Once you've created a profile and kind of search in the area that you want to look up, it'll populate a list of providers in that area, and you can kind of search around from there. But the really neat thing about it is that there's many different ways to filter through the providers. So you can kind of search with like specialty areas, their location in Iowa, the insurances that they accept. You can also choose in person or virtual if they have a preference for that. as well as insurances that they take, I mentioned. There's also an insurance benefit verification in there. I typically encourage parents and families to verify themselves just to make sure that it's accurate within the website, but there is a functionality in there for that too. Yeah, and then there's also a really neat feature in there that if you're a provider and want to create a list for parents and families that you're working with, you can kind of get what they're looking for in providers and then create a PDF version of that list, and then provide them that as a resource, either virtual or create them printed off for them. So that's something that I really like to touch on with parents and families, that either they can do for themselves or you as the provider can do it and print it off for them too. And then there's a lot of neat little features in there. A couple things I wanted to be sure to highlight is there's a frequently asked questions page for parents. So as they're navigating the mental health realm, there's a lot of things that are uncertain that parents have questions on. And so there's a page on kind of how to navigate some of those conversations that's linked here. And then there's videos in there as well on how to search for providers, contacting them, and things like that, if you have somebody who you're working with who's maybe more of a visual person in that way. So those are some key things that I like to touch on about Welltrack Connect. Again, it's an online platform. Getting signed up, if my slides will advance. There we go. If you're working with parents and families, they can create a profile so they can look up providers themselves. So to do that, you can encourage them to go to welltrack-connect.com. Up at the top, there's a sign up button. It's just select that and it pulls open a new page for the sign up page. I like to highlight, there's a question, are you a student or parent supporting your student? And it's just yes, no. You want to encourage them to say yes so that they can opt into the service. And then they just follow the prompts. And if you are a mental health provider and you want to create a profile and be listed on Welltrack, there's two different routes you can go. Either you can go to that same website, welltrack-connect.com, and then you would opt for the list your practice and then follow the prompts. Or you can email our clinic email at scsmh-clinic@uiowa.edu. I have a function that we can push through administratively to prompt that service for you. So just kind of your preference as well. But I want to encourage providers to be sure to get their profiles listed so that as parents and families are utilizing Welltrack, there's plenty of options out there. And that's Welltrack Connect.
Thanks, Liz. Can I ask you, how often are you guys curating the information?
Sorry, can you repeat that question?
How often are you curating the information?
So I haven't gone in there. I have we have a page to view how many people are listed, and then providers can be listed as a part of like the Scanlon community or not. It doesn't really matter. They still populate up either way. But it's also up to providers to kind of keep their profiles up to date, and Welltrack has a function that will kind of prompt you to make sure that it's up to date as well.
Oh, so that once a provider has populated themselves, they might receive like an email to say, hey, are you still
just checking in?
Did you leave Iowa? Or you that would be the biggest thing or did you retire? Or
yes, that's a good question.
Yeah. Okay. Wow. That's great. That's so great. Thank you so much. Did you have anything else you wanted to touch on?
Nope, that was all for me. Thank you, Dr. Stevens.
Oh, fantastic. Okay, let me see about sharing my screen to share about our resource, our college medicine resource. Let me just put it up here. Everybody see that okay? Okay, great. So, as I had introduced myself in the beginning and Coffee reminded you, I'm the head of child psychiatry here at the University of Iowa Hospitals and Clinics. And we are very fortunate that among, all the different medical specialties, this is true for, that since we have the specialists here at the university on call 24/7, we leverage that availability into this ability of practitioners to call in and consult with specialists. And in this case, practitioners can call in and consult with a child and adolescent psychiatrist at any time, 24 hours a day, 7 days a week. And that's to talk to the actual medical specialist we're talking about here. That is something that we provide to practitioners in the state. That's not available to, let's say, teachers or families. They would be directed differently in the system if they were calling for immediate needs. But if you're a primary care practitioner, a pediatrician, a family medicine doctor, an emergency room doctor, advanced practice provider trying to do work in child and adolescent mental health, we have this ability to call in and talk to a specialist, just maybe about any general kind of question. We have some examples of questions that we have received at the consult line and do come up repeatedly. Things like, I've got this specific clinical problem in this patient. I know about this thing, this first line thing, but then what do I do if that's not working? I have a particular situation and I have never thought about how do I give guidance to parents. Do you have some thoughts for me? What kind of resources could be offered for a specific clinical problem? Liz has already given us a great resource for finding other resources, but sometimes you want something more specific, directed, and you're looking not necessarily for a therapist, but maybe handouts you can use in your office or other things you can tell families about. For a particular behavioral issue that's coming up, are there approaches that you would recommend? What kind of screening tools could I use? Dr. Elliott told us today about anxiety disorder. Dr. Elliott and Dr. Elizalde, they told us about screening tools for anxiety disorders, but obviously there's some for all different parts of the child mental health spectrum, and we can help with that. Sometimes it's general questions, although I would say as a person who answers calls on this consult line pretty frequently, a lot of times it's about a specific patient coming in. I'm going to be seeing this patient this afternoon. I really I'm sort of struggling with some knowing what to do about the particular issues in the case. So here's an example of a 5-year-old with disruptive behavior, and I've been thinking about treating for ADHD, but some of the reports are discrepant. Can you help me think through? It's almost just like being back in training and having a person who has a little more experience with something available to you to just run something by and do a little back and forth question answer more than it might be possible through your basic internet search or just searching for a paper and or a textbook on the topic. I personally find it very meaningful and really satisfying to be able to have these conversations with folks out in the community, to know that we're meeting needs at that broad level and doing it through general conversations, specific case-based conversations that can range the wide gamut of topic. So just wanted to remind everybody, this has been in place for years here at the university, so we're not telling you something that's new, unlike Welltrack Connect, which is a really new, wonderful resource. But it's just that, I think people get busy and they kind of forget what's available, when it could be really nice to be reminded, hey, there is a way I can tap into, an expert in a particular area just by giving the university a call and getting connected up. So just wanted to remind people about that resource. And we have that here at the, you can always be like, oh, what was that thing they told me about that day? You can always search for that on the internet, coming to the University of Iowa Hospital's webpage. You'll find that information too. And if you're really like me, and I just trust that if I call an operator, they'll know what to do with me. You can often do that too at the university. Just give the hospital a call and say, this is what I'm trying to do. And they'll probably get you to the right place. But, yeah, so I think that brings us to the end of our time, Coffee.
Yes. We did have one question since we have time. Maybe we can. How quick is the response to this UI consult? What response time should they expect?
Yeah, well, it can be variable, and I would say, we have had some snafus where we've had times when people didn't get a response, but that is not what's supposed to happen. So, the majority of the time we have people calling back within, 15, 20 minutes. The operator is the one who will maybe take the call. They'll try to reach out to the person on call. They likely will not keep the person calling on the line because they may say, this might take 5 or 10 minutes. I don't want you to sit here and waste your time. I'll reach back out again when I get my person calling back and then connect up. There have been times when practitioners have said, simply because usually we're doing this on call in addition to other things we're doing, and has said, I just got tied up with something. Is this something that I can call the person back about like in an hour when I know I'm going to be free? And hopefully that communication happens. But yeah, it should be able to be done definitely same day, definitely quickly, usually within that kind of 20-minute range.
Okay, well, thank you. And I did put, just for everyone, that I did put the link to the Welltrack website as well as the UI console postcard that you can print and kind of have there available for you to use. And so,
Thanks, Coffee.
yes. Okay, so well, thank you everyone for joining. This will conclude our conference today. I want to extend a sincere thank you to all of our speakers for sharing their knowledge and expertise, and just the contributions really made this a truly impactful day. And thank you to everyone who participated today and for being part of this important conversation. I hope you found the sessions informative and valuable to your work. Following the session, you will receive an email with the link and instructions for how to claim continuing education credit. I also uploaded it to the chat, as well as I will send the link to the recording and to the handouts. It may take a couple days to get those uploaded, but those should be available for you at the links provided. For any questions, please feel free to reach out to me at kafi-dixon, DIXON, @uiowa.edu. And thanks everyone, and have a great afternoon.